Hello everyone, a very good morning to all the speakers and delegates present over here. Hello Dr. Richard, sorry for keeping you waiting. Actually, we are waiting for the other participants to join as well. We'll just wait for 2 minutes more, and if they have joined already, we can start the session. Thank you for waiting and waiting.
There you go. My mic's on.
Hello. I think the participants will be joining shortly. Start the meeting. Can you hear me, Doctor?
Sounds very spotty.
Just a second. I'd like to start once again. Very good morning to all the speakers and delegates present. I am Anamara, and I'll be moderating at this virtual session. On behalf of Scholars Conferences, it gives me immense pleasure to cordially invite you to the World Congress on Otology, Rhinology, and Laryngology. I thank you all for finding your time from your busy schedule and joining us today. With that being said, now I'd like to call our first speaker, a keynote speaker, Dr. Richard Poker, and I have kept him waiting for so long. I apologize for that. Dr. Richard Poker from Sarasota, Florida, USA, to deliver his keynote speech on what a candidate for a cochlear implant needs to do. Welcome, Doctor. Once again. You can now start your presentation.
You have the slides that I had, Kate, that I sent you. You have slides?
Yeah.
Okay, you want to put those in?
Okay, sure. Just give me a second.
Sure. Hope she gets the slides. Give her a second. While we're waiting for the slides, I'll introduce myself and we'll worry about the images later because it's not that important. My name is Richard Parker. I was totally deaf for 35 years. I had progressive hearing loss from scarlet fever when I was 7. And then when I was 30, I lost all my hearing within 1 month. And at that time, cochlear implants were very, very primitive. And I did not want to lose the fidelity of music. So I waited and waited for a cure. I waited 35 years. And I moved to Florida 9 years ago. And I went into a Costco and I looked at the hearing aid display. And I said, maybe something's changed in 35 years. Maybe hearing aids will work for me again. And I went for hearing tests. And of course, there was nothing there. There was no way a hearing aid was going to help because my hearing was gone, totally gone. And there we go. Oh, look at that. Okay, so cochlear implant basics is basically what I did for the past. I received bilateral cochlear implant surgery, which is very rare, 2 of them done at the same time. I went from 0 speech recognition to 85% with rehabilitation. And this was 2016 was when I was activated. And since that time, I've mentored hundreds and hundreds of candidates moving forward out of the isolation of deafness. And I do this basically through my website, which is called cochlearimplantbasics.com. And I have 5 different Facebook sites. I'm on Facebook at least 50 to 60 hours a week. I work in 24 time zones. I never sleep. Can we go to the next slide, please? Okay, that's where I am. And my disclaimer is this. Go back one. I am a volunteer. There are 3 different companies that make cochlear implants, Cochlear, Advanced Bionics, Metal. There are some other smaller ones. I'm a volunteer for Cochlear, but I do not get compensated for anything. Next slide, please. Next slide, please. Oops. And what I did with my podcast are all transcribed. I have podcasts with candidates, surgeons, audiologists, all sorts of people involved with cochlear implants. And in 2022, I took all those podcasts and combined them into a book, the transcripts. And I published a book in 7 languages, which would reach about 50% of the world's population. The book's available on Amazon. I sell the Kindle edition for 99 cents. My objective is not to make money, but to disseminate the information. Next slide, please. So some of these candidates that I've worked with, I've mentored hundreds and hundreds of people out of the isolation of deafness. This is what I do. This is my mission. And what I basically want to do is help people overcome the misconceptions about cochlear implants, which happen all the time. And in fact, last night, I was on one of the Facebook sites and I saw somebody post about their nephrologist telling them since they had sensory neural deafness, there was no way they could get their hearing back. And this is from a doctor. And I explained to them that, let's just take the United States, for example. We have about 400,000 people with cochlear implants out of 330 million people. So your chances of meeting somebody with a cochlear implant is still very small, and the misconceptions exist. I try to combat this by doing speeches like this. I have a YouTube channel. It is very, very difficult to overcome the misconceptions about cochlear implants. But when you get somebody like John, who finally gets it, hopelessness is overcome and they move forward. That's my reward. Next slide, please. And people often said to me for 35 years, you don't look deaf. Well, this is another one. What's a typical deaf person look like? There is no typical deaf person. And we have to understand, or at least I hope to convey the message, that people without a hearing loss, it's almost impossible for them to understand what it's like. And I get that, because like any medical problem or any disability, unless you see it, unless you experience it, you really have no idea. So my mission here is to let people know there's no typical deaf person. And on my podcast at Cochlear Implant Basics, you can go through 35 different interviews. I realize in this day and age that people don't have the patience for anything more than 3 minutes. And my objective was slightly different. My podcast lasts 20 to 30 minutes, because if you want all the information, I wanted to be sure it was there. Next slide, please. Mike Daly was one of my inspirational. He's a emergency medical technician with 2 cochlear implants. And you can see his message here, that he basically said, I motivated him to move forward, get the second one. And he realized that nothing can stop him. There's no limitation to somebody who can hear and move forward with their cochlear implants. This guy is tough. He was a fireman wearing 2 cochlear implants. Next slide, please. I'm not sure if this is going to get lost in translation or not, but this is the kind of thing we try to do with humor to get people to understand cochlear implants or hearing loss. Hearing loss itself does not have to be tolerated. There's some way to move forward. Next slide, please. Okay, music. This woman, Nanette, was the lead singer for a very popular group back in the 60s, 70s, and 80s, and she lost her hearing. And she's a part of the interviews, one of the interviews I did, because music, many people, myself included, found that the loss of music was more intolerable than the loss of speech. And again, this was one of the reasons in the very beginning, back in 1980, when I lost my hearing, I decided not to get a cochlear implant because music was too important to me. And I did not realize, I was under the same misconception many people were. I did not realize the technology had improved to the point where music was enjoyable again. And so this is one of the podcasts I have to explain about music on my site. Next slide, please. Okay, he was 14 months old when he received bilateral cochlear implants. And he's doing fabulously. I think we just passed the 1.5-year anniversary. He's doing fabulously. What we have to understand here is the earlier intervention, the better chance of getting good results. There's a window of opportunity for speech development. And we understand that basically because of our differences in accents. What we pick up by the age of 3, unless we're a phenomenal actor, our accents will stay with us for the rest of our lives because of the plasticity of the brain. So early intervention is critical. In the United States, most cities now require a hearing test almost at birth to understand if the child has a hearing loss. Rather than wait till they're 5 or 6 years old or 3 years old, you want intervention as early as possible. I believe the earliest bilateral cochlear implant inserted was a 9-month-old child, but the child's head was fairly large and the surgeon was able to do that. Most cochlear implants are done one at a time, both for insurance purposes and the skill of the surgeon. I was very fortunate to find a surgeon who was willing to do 2 at the same time. He had a lot of experience in that. Next slide, please. Okay, this is another interview. This is another interview that I think is very important. If you want to understand about pediatric intervention, Cynthia has over 4 decades of experience, and she's the one that her interview explains about the plasticity of the brain. It's not impossible if you've missed the window to get speech, but your speech will never be as clear. Next slide, please. Now, this is one of the very important mentors I had when I was looking at cochlear implants. Jack had meningitis when he was 11 years old. He received a cochlear implant 30 years before me. And again, they were very primitive. But when you have the implant inserted, it's for life. The technology, the improvement in technology is in the external part. I'm sure this is what a cochlear implant looks like. The internal part stays there. It never changes. And I'm on the third generation of improvement since I was implanted. Jack, when I met him, was on the 7th generation because he was implanted so early. The internal part stays there. Now, I asked, of course, when I was investigating, well, how long does the internal part last? And I was told by Cochlear 75 years, which means the surgeon who's going to re-implant me when I'm 130 hasn't been born yet. So the reliability is very, very important. Jack is an amazing guy. He also explained to me, he runs marathons. I don't know if he does now, but he ran marathons in the rain while wearing his cochlear implant. And Cochlear's manufacturing was so watertight, he was able to do it without a problem. Next slide, please. Next slide, please. This is one of the things that I constantly remind people. The hearing loss does not have to be a barrier. Even if you don't get a cochlear implant, you can push forward, but you're going to get much, much further if you get your hearing there. And remember, when I lost my hearing at 30, I had a business, I had 5 locations, and I had 35 employees. I could not stop working. I could not make a phone call for 35 years. I always had to have people make a phone call for me. And the only regret I have about cochlear implants is I didn't do it about 10 years earlier because the technology had already caught up. And I was holding on to the misconceptions. The misconceptions are horrible. They're still here today. Next slide, please. And this is Lou Ferrigno. He's a star of the Incredible Hulk. And Lou was one of the prime examples. He received a cochlear implant in 2021. He was like me. I'm not a bodybuilder, obviously, but our stories are fairly similar about the time we lost our hearing, all the struggles we went through, and we got hearing aids about the same age, and we got cochlear implants about the same age. And one of the things I interviewed Lou about was in 2021, he had just received a cochlear implant a few months before, and his speech was okay, but not great, because again, his speech was not great, but it was improving after 3 or 4 months. A year later, I interviewed him a second time, and that's when his speech had improved dramatically. Both those interviews are on my website. The lesson learned here was that cochlear implants are not magic bullets. You have to have rehabilitation to get the best results. On my website, there's a link, 2 links at the top for rehabilitation, gives all the tips for speech rehabilitation. And I also created a program for music rehabilitation by enlisting 28 of the world's best musicians to give me 2-minute clips of their particular instrument, so that the brain has to learn again what a guitar sounds like, what drums sound like. You can go through this over and over again until your brain kicks in. Next slide, please. Okay, this is me at the age of 7 or 8, probably. Those are my That's my email address. You're always welcome to contact me if you have questions. The book is available on, here's the book. It's available on Amazon. And like I say, it's available in 7 different languages. So if you have clients, French, Italian, German, Portuguese, and German, what else? Oh God, Hindi. It's available in Hindi as well. So if you have questions, you want to put them in the chat box or you want to open up, I'm here for you. Okay, also on Facebook, if you go, and LinkedIn as well, if you go to LinkedIn, punch in my name, all my posts are there. And Facebook, I have 5 different sites. The biggest one being Hearing Loss, the emotional side, which we have over 2,000 members on that. I run support meetings every Thursday night where people can come and talk about the emotional side of the hearing loss, which is very deep. Going back one step, when I had my sudden hearing loss when I was 30, I went into a tailspin. Obviously, it's very traumatic. And I got some therapy for about a year. So that you have to be aware that if you're dealing with somebody with a hearing loss, there's going to be a big emotional component. If you're an audiologist or surgeon, unlike replacing somebody's knee or a hip, you're dealing with an implant that you're going to be responsible for the rest of that patient's life. The surgeon, not so much. The audiologist will be, because they're constantly going to need adjustments. You're going to need fine tuning. There'll be technology advanced. You can't just walk away from the patient. A lot of hand-holding in the beginning. And this is what I did, basically want to get the message across that, again, last night, like I said, somebody was online and the nephrologist told them, oh, you can't do anything about your hearing loss. And I said, wait a second, that's not right. That's not right. And she said to me, well, he says I have sensory neural hearing loss and it can't be fixed. I said, every single cochlear implant recipient in the world has sensory neural hearing loss. So it's not quite true. I'm talking about the medical profession should know more. And that's my message. I appreciate your time. I appreciate your help in getting the word out. And anything I can do, you have my email there. I'm always open to answering questions. So thank you very much.
Thank you so much for your valuable presentation, doctor. If anyone have,
Wait a second. I want to be clear. I'm not a doctor. I'm a
okay.
okay.
Thank you so
All
much,
right.
dear.
Thank you so much.
If
Thank you,
anyone
everyone.
have any questions, please feel to ask. In case if anyone don't have any questions, we will forward this to next speaker. Thank you so much, dear. Now I will begin the speaker session. I call upon Ying Yang, Binzhou Medical University from China to deliver a talk on cross-cultural adaptation, reliability, and validity of the Chinese version of the acceptance and action questionnaire hearing loss. He could not join us today, so I'll be playing a video presentation.
Hello, moderator. I'm the Dr. Yin Yang. I come from China. Can you show my slide?
Hello, doctor. You're welcome.
Hello. Can you share my PowerPoint?
Will you be able to share a screen? Hello.
Hello. Can you hear me?
Yes, doctor. Will you be
Yes.
able to?
Doctor, do you want me to share the video presentation or you'll be sharing it yourself? Let me know.
You can also show my video. Okay. Okay.
If you prefer, you can also share. No issues. Whatever you prefer. Do you want me to start it?
Mm,
Yes, we can see your slides.
Can you see my PowerPoint?
Yeah, we can see.
Okay. Good morning, everyone. It's my pleasure to give a presentation here as a doctor whose major is hearing and speech rehabilitation. I'd like to introduce an assessment method for psychological flexibility in Mandarin speaking adults with hearing loss today. The cross-cultural adaptation, reliability, and validity of the Chinese version of the acceptance and action questionnaire adult hearing loss. As the PowerPoint shows, my presentation is mainly divided into 5 parts. Firstly, let me introduce the background and significance. According to the World Health Report released by the World Health Organization 2021, nearly 20% of people suffer from hearing loss. Hearing loss can cause not only auditory, speech, and language impairments, but also cognitive decline, as well as social communication problems and psychological problems. By 2050, it is estimated that 2.5 billion people will experience hearing loss, with nearly 700 million people living with moderate or higher levels of hearing loss. In adults with congenital hearing loss, those issues are also a major concern for clinicians and families. Prior studies reported that hearing impaired people have a threefold higher risk of developing social and emotional deficiencies in everyday life. A study conducted in Nigeria comparing the prevalence of psychopathology between the hearing impaired and healthy adults found that psychopathology was present in 19% hearing impairment adolescents compared with 4% adolescents in the control group, with the most common diagnosis being generalized anxiety disorder and depression. An investigation into the mental health of adults with severe levels of hearing impairment in the Netherlands showed that the prelingual and postlingual deaf men reported mental distress 27.1% and 27.7% respectively. And among women, those figures are 32.4% and 43.2%. Those rates are higher than in the general population. Although treatments for hearing loss can elevate function impairment, psychological factors such as psychological inflexibility may impact treatment participation and adherence, which can diminish the benefit of treatment. Growing evidence has suggested that the early detection and intervention for people with mental health problems may ameliorate associated distress, reduce symptoms, improve the quality of life of patients and their caregivers. By assessing and improving the mental state of people with hearing loss, it may be possible to further improve their adherence to recommendations for device use and management, which may result in positive auditory rehabilitation progress feedback loop. Psychological inflexibility refers to persistent patterns of behavior that are primarily guided by internal experience, typically to avoid certain thoughts, feelings, and sensations in a way that is disconnected from direct environmental events and personal goals and values. Previous research has shown that psychological inflexibility has a direct effect on life satisfaction and significantly contributes to daily well-being and lasting psychological health. The Acceptance and Action Questionnaire refers to AAQ as the most widely used scale to assess experimental avoidance and psychological inflexibility, and has wide-ranging application. For example, pain, psychiatric treatment, stigma, and college students. Those specific versions of AAQ are excellent at predicting psychological outcomes and providing guidance for psychological intervention in their prospective domains. In 2019, undeveloped the English version Acceptance and Action Questionnaire Adult Hearing Loss refers to AAQ-AHL, which is psychometrically psychological outcomes and may be a useful measure to assess the degree of psychological inflexibility associated with hearing loss in adults. There are three areas of clinical significance. The AAQ-AHL significantly predicted psychological relevant outcomes, and it is a useful measure to assess the degree of psychological inflexibility associated with hearing loss in adults. And audiologists may be interested in incorporating assessment of hearing loss psychological inflexibility in their treatment plan and using it to shape intervention and patient goals. Currently, research tools to investigate the psychological status of people with hearing loss in China are limited. Following the work of ON, firstly, we validated the Chinese version of the AAQ-AHL in people with hearing loss in mainland China. The AAQ-AHL instruments use 7 response options in previous study in on study. However, there is currently no consensus on the number of response options that would optimize the psychometric prosperities of the skill. So we reduce the response items of the skill from 7 to 5 to verify the effect of the scale. Moreover, because some measurement tools are validated in vendor age ranges, we also applied a vendor age range for verifying the AQAHL to expand the skill's clinical research utility. Next, I will introduce the part 2 materials and methods. Students with hearing loss are recruited from special education schools. A total of 402 students aged over 12 years participated in this study and completed the questionnaire online. Of the 108 students who participated in the verification phase, there were 30 items clarity testers and 78 test reliability testers who complete the AQAHL only. 294 students complete 3 questionnaires online, including demographic information, AQAHL, and the Chinese version of depression, anxiety, and stress 21 skill. The 12-item AQAHL was developed to assess psychological inflexibility in teenagers and adults with hearing loss. Response items are rated from 0 never to 4 always. We use the Chinese version of BAIS 21 skill to assess the mental health status of the participants. This is the English version of the AAQ-AHL. The items are rated from 0 never true to 6 always true. This is the Chinese version of the AAQ-AHL. The skill was translated into Chinese by 8 different translators following the guidelines for cross-cultural adaptation. Finally, 30 subjects completed the questionnaire and were interviewed on the clarity of the items. Reliability was determined by internal consistency using Columbus alpha coefficient, and test reliability determined by intra-class correlation coefficients refers to ICC. The validity analysis include content and construct validity and criterion validity. Subsequently, the optimal cut-off score of AAQ-AHL was established using the receiver operating characteristic curve. Now let's interrupt the results. The assessment of content validity was performed by experts in Otology who analyzed the representativeness of resources and translated each items of AAQ-AHL and the skill as a whole. The experts confirmed the skill's phase and content validity and agreed that the skill was aligned with its purpose of assessing psychological inflexibility and that the items of the questionnaire represent the target outcomes. Test retest validity showed an ICC of 0.815 for the two total scores, which indicated a good levels of reliability. Using exploratory factor analysis, we extracted two factors with characteristic rooms greater than 1 from 12 items. The cumulative veteran contribution rate was 61.58%, which indicated good overall data interpretation capability. The factor loading table shows that the common factor 1 was primarily associated. The factor 1 was primarily associated with variables describing advanced behavior for hearing loss. The factor 1 includes items 3, 4, 7, 8, 9, 10, 11, and 12. Whereas factor 2 was associated with adaptive acceptance of hearing loss, including items 1, 2, 5, and 6. All items had high loadings on a single factor, which ranged from 0.648 to 0.886. Therefore, the structures of the skill conform to the expected content framework, which reflected good structural validity. Results show that Columbus alpha coefficient of the AQAHL is 0.829. Columbus coefficiency of factor 1 and 2 were 0.883 and 0.860 respectively. In general, high coefficients indicated that the AQAHL had good internal consistency when applied to different age groups of people with hearing loss in mainland China. The total AQAHL score was significantly correlated with the stress, depression, and the total DASS-21 scores, but not with the anxiety score. We use the Chinese version DASS-21 total score as an index for general psychological distress of adult with teenager and adult with hearing loss in this study. Based on DASS-21 normals, a total score of 32 is considered to represent clinical elevated levels of general psychological distress. Subsequently, the ROC curve was used to establish the optimal cutoff score for the AQAHL. The ROC curve analysis shows that AQAHL can distinguish between the presence or absence of psychological distress with an area under the curve of 0.594. The results show that an AQAHL total score of 20.5 rounded to 21 was the optimal cutoff point, implying that individuals with score lower than 21 had higher psychological flexibility and less likely to experience significant psychological distress. At this point, the sensitivity was 0.466 and the specificity was 0.307. Now let's enter the discussion and conclusion part. Gaining insight into the usefulness and the feasibility of measuring psychological inflexibility is an important step towards developing studies on psychological intervention for people with hearing loss. Therefore, we aim to develop a Chinese version of the AAQ-AHL to measure psychological inflexibility. Cross-cultural adaptation was performed to obtain semantic, linguistic, experimental, and conceptual equivalence according to the international cross-cultural adaptation guidelines to ensure the accuracy of the content of the questionnaire. Second, we conducted reliability and validity tests for the Chinese version of the AAQ-AHL. In our study, the ICC for the 12 items AAQ-AHL total score was 0.815, which indicated acceptable test-retest reliability. Internal consistency of the scale was calculated using Columbus alpha. Acceptable alpha value ranged between 0.7 and 0.95, with higher scores indicating increased interrelatedness. In our study, Columbus alpha of all test items was higher than 0.79, which indicated homogeneity of the translated Chinese items. Structural validity is also an important indicator of the accuracy and validity of the assessment. The AAQ-AHL reflects not only the rigid psychology and negative emotions of hearing loss, but also the positive behaviors required to overcome hearing loss, which confirms the good structural validity of the Chinese version of the AAQ-AHL. Furthermore, we verified the criterion validity of the questionnaire. We compared the AAQ-AHL score of the verification version with the Chinese version DASS-21 score. The AAQ-AHL score was significantly correlated with the DSS stress and depression subscale. However, it is worth noting that the correlation coefficient was not high. This may be because the DSS-21 scale is a psychological tool that is applied to the general population to assess negative emotions, whereas the AAQ-AHL is applied to the general population to assessing the psychological conditions related to hearing loss. Importantly, when assessing the cutoff point score of AAQ-AHL, we found that nearly 40% of adolescents and adults of hearing loss had varying degrees of psychological inflexibility, which warrants attention. Mental health problems in people with hearing loss warrant the close attention of medical workers. Hearing loss leads to poor psychological outcomes. such as lower levels of well-being and self-efficacy. The use of the AAQ-AHL can facilitate the development and delivery of psychological intervention programs for this population. Thus, with the above results, we can obtain two main conclusions. The psychometric characteristic of the Chinese version of the AAQ-AHL showed satisfactory test reliability, internal consistency, content validity, structural validity, and criterion validity. It may be used as an outcome indicator of individuals with hearing loss following psychological intervention programs. However, our study has several limitations. Firstly, although all participants resided in various Chinese cities, the questionnaire was completed most by students. And the degree of hearing loss ranged from severe to profound. The sample size was not large. Thirdly, the change from a 7-point to 5-point scale did not affect the reliability or accuracy of the AAQ-AHL. While it limits the comparison of our results with those of other studies that use the original instrument. Those two pictures are from my university where I do my work. The one on the left is the Binzhou campus, and the one on the right is the Yantai campus. Now our undergraduate and graduate students are mainly cultivated in Yantai campus. Welcome schools to Yantai for exchange and guidance works. Thanks for attention, and thank you very much for invitation and the moderate introduction. Thanks for attention.
Hello, am I audible?
Hello.
Hello, doctor. Am I audible? Hello.
Hello. Hello.
Yes. Thank you so much for your presentation, doctor. If anyone have any questions, please feel free to ask. Anyone have any questions?
I have a question.
Yes. Yes, doctor. Proceed.
Okay, my question is this. I find often, not often, but in the United States, I find cochlear implant doctors do not do any psychological testing. And sometimes they create a problem by giving that patient a cochlear implant who's unable to handle that. Have you experienced anything like that?
Thanks for your question. I'm an audiologist, and I'm also Otology head and neck surgery, and I'm also a doctor. I also worked in otology head and neck surgery. Most doctor most doctor cannot pay much attention to the psychological psychological problems during the work in China. This is a issue and phenomenon currently mainly in our work. So when I during my work, during my work, I also found this problems. I wanted to do some work on this on this. So
I appreciate that. You know, I found your presentation absolutely fascinating because I mentor in 24 time zones, and Cochlear works in 80 different countries. And I have to constantly be aware of cultural differences when I'm talking to candidates. So I thank you for your presentation because it's opened up a new door for me to think about.
Thank you. Thank you for your attention. There are many works to do, especially in China. The first cochlear implant in China is in 1995. And we experienced nearly 30 years. It worked on work on the cochlear implantation and focus on the teenagers and adults and child with hearing loss. And there are many works to do in the future. So especially in the mental health problem. So we can do much work in the future.
Okay, thank you, doctor. Next, we will go to next speaker after a short break for 5 minutes. Please don't leave the room. We will start the session after 5 minutes break. Thank you. Hello. Let's start the session. Can you hear me, doctors?
Yes.
Yes, doctor, we will start the session with the next speaker. I call upon Mary Arabola from Empower School of Health, Switzerland to deliver talk on the rising need for a population health approach in otology. Hello, Dr. Mary. You're welcome. You can proceed with the presentation. Can you hear me?
Hello, everyone. Yes, can you
Yes,
hear me?
doctor. Yes.
I shall just begin. Today, I'll be talking about the rising need for a population health approach in otolaryngology. Hello, everybody. My name is Mary. I have a background in public health and supply chain. I work as a public health consultant and an learning instructional designer with the Empower School of Health. I believe you can see my screen. This was a screenshot that I took some days ago. I conducted a search on the 8th of July, to be precise, on Google Scholar, and I put in public health cardiology. And you see, we have over 1.5 million results, and majority of the results are relevant to the search terms. But when we go to public health diabetes, we have over 3 million results, all of which are relevant. But when we come to public health, population health, otolaryngology, we have about just 796,000 results, and majority of the results are not even relevant to the search terms because there isn't so much information, there isn't so much done in the field of otolaryngology as regards to public health. One of the results from the previous slides, this is the abstract from one of the studies. Accountable care organizations represent a shift in healthcare delivery while providing a significant potential for improved quality and coordination of care across multiple settings. Otolaryngologists have an opportunity to become leaders in this expanding area. However, this field currently lacks many of the tools necessary to implement value-based care, including performance measurement, electronic health infrastructure, and data management. And once we have these resources, they will become increasingly important for surgical specialists to be active participants in population health. So what is population health? Because I am saying that there is a need. Okay. Just a minute, let me share my screen. I'm saying that there is a need for otolaryngology to involve population health. Population health is often confused with public health, and public health traditionally focuses on national and regional government dealing. Just a minute, please. I want to maximize my slides. Population health, yes, okay. Population health is often confused with public health, which traditionally focuses on the way national or regional government deal with the prevention and the spread of harmful epidemics and environmental hazards. So public health talks about the intervention of government with the health sector, whereas the traditional or the conventional medical approach talks about, patients fall ill and then they are treated. Public health focuses more on preventing the patients from falling ill. So public health focuses on the government cooperating with the health sector, with the doctors to make sure to address why people fall ill, and then to assess those determinants and then, prevent them from happening. But population health is slightly different. Both are concerned with the overall health of the general population, although population health tends to focus on smaller groups, smaller specific groups. So public health focuses on everybody, then so you can talk about an entire nation, an entire continent, an entire region, or even global public health. But population health focuses on a specific group. So speaking to otolaryngologists, it's more population health would focus on the patients that you see, the patients with the specific, conditions that are unique to your field. The World Health Organization defines public health as all organized measures, whether public or private, to prevent disease, promote health, and prolong life among the population as a whole. One of the key differences between population health and public health is that while public health focuses on the general public, like I've mentioned, population health streamlines and it focuses on the select subgroup of population. Population health is the interdisciplinary approach to achieving positive health outcomes within a community. So when we talk about getting involved or translating to population health, it's not just going to involve only the doctors anymore. It's going to be interdisciplinary. We're going to need epidemiologists and biostatisticians and people that deal with health law and ethics and people in politics, because we are addressing every single factor that contributes to a disease outcome, every single outcome that factor or determinant that influences the health outcomes of a particular group. A community can refer to a nation, an ethnic group, a city, or something more specific, such as a group of disabled students or a specific pool of patients. So for a particular doctor, your population can be a specific group of patients of a specific race or ethnic group in a specific location. Health researchers propose that the definition of population health should be the health outcomes of a group of individuals, including the distribution of such outcomes within the group, and that policies and interventions are what link the outcomes to the patterns of health determinants. People's health outcomes are not in isolation. Someone doesn't just randomly fall ill. There are so many factors that contribute to a particular health outcome. If someone comes up and there is let's say there's something going on with the hearing, it's not random. There are either biological factors, genetic factors, environmental factors, or socioeconomic factors, or even political factors that would all contribute to the specific outcome. Why do we then need population health? So today I'm not here to tell you how to do jobs or how to treat your patients. I'm here to propose the argument, and rather than focusing on the conventional approach to treating the patient, perhaps we can consider, because you understand that globally there is a transition from conventional medicine to more public health and population health. There is a shift from focusing solely on cures and to preventative measures and palliative measures. Population health is all about maximizing health outcomes in a select population or community. Maximizing health outcomes is the key word, maximizing the health outcomes. We are not trying to suddenly come, to control control the people, but we're trying to maximize the health outcomes. There are certain outcomes that cannot be prevented. There are certain outcomes that can be mitigated. There are certain outcomes that interventions can come on much earlier on, and so that the standard of living, the daily adjusted life years, is not so much an impact on the people. The main goal is that people live as healthy as possible. The main goal is to make sure that people live the most healthy life that can be afforded to them. Not necessarily the most healthy life they are aware of, but that they have everything needed to have the maximized health outcomes. Health determinants that affect these outcomes, like I mentioned earlier, can be genetics. So people can be born and already genetically predisposed to certain conditions. However, there have been several studies that show that someone being genetically predisposed to something doesn't necessarily guarantee that they will have that outcome, because genetics it doesn't work alone. There are other factors. So we have the social environment, education, income level, employment status, culture, the environment that people live, physical or natural. Is there clean air? Is there clean water? What's the urban infrastructure like? Do they live close to certain technological spaces? Do they live close to construction sites? The design of the environment they live in. What is the healthcare system where they're based? Do they have access to healthcare services? So since we're speaking to otolaryngology, someone can have hearing problems, but if they don't have the system, or if they don't have access to healthcare systems and they're aware that, okay, I can get cochlear implants and I will have a maximized standard of living, they will just stay there because they don't have access. And access is not just you live here, and the clinic is 10 miles away. No, access is you can go there and you can afford the services being provided to you. To be surprised to know how many people do not have cochlear implants simply because they cannot afford it. Another determinant is individual behavior. So we can put all those things in place, but ultimately people make choices. People make choices that inform their health status. Population health experts use data to understand how these factors impact health and health distribution, identifying specific needs so that the communities can address these concerns and ultimately improve their health outcome. So population health experts analyze data. You look at a specific community, a specific subgroup. So you can notice in your 30 plus years of experience that people from this particular, socio-economic environment, or people from this particular race, or people from this particular age group have these same symptoms. The question now is, okay, they have the symptoms. It's okay, we can treat them and give them medical attention. But beyond that, why are these symptoms, peculiar to these people? So you identify the specific needs, what is common to them. That's how we go downstream rather than upstream. So you take it down. These are the symptoms. What causes them? What is common to all these people? And then we identify them. Once they are identified, they are called determinants. We know that addressing those determinants can significantly reduce the frequency of the occurrence of the symptoms. Population health is important because it addresses entire populations at a macro level. So it's not just about one patient, it's about 50 patients who have similar health statistics, who have similar health information, who are prone to the same thing. And this helps identify structural inequalities for law and policymakers so that efficiency and quality of care can be improved. So if people in a specific geographical location have a certain health outcome, and let's say the issue is they don't have access to health services. Now we know that that's a structural inequality. And now we involve, remember earlier on I mentioned it is multidisciplinary. It's not a doctor's job to make sure that there are health facilities there. And then we involve the appropriate disciplines, the appropriate channels, so that these inequalities can be addressed and that efficiency and the quality of care can be improved. The World Health Organization suggests that over 5% of the world's population require rehabilitation to address their disabling hearing loss. So about 430 million people do not have access to the services needed to address their disabling hearing loss. And it's not that the services are not available. It's not that technology isn't that advanced, but the issue is there are people in different population, in different subgroups who for several reasons and determinants are having their health outcomes affected. By the year 2050, nearly 2.5 billion people are projected to have some degree of hearing loss, and at least 700 million will require hearing rehabilitation. So except we want to have a huge proportion of the people in the world not living the best life they can live, not living as healthy as they can, we need to be more proactive. We need to involve population and public health. We need to step out from the box, from the conventional way of just, treating people and doing what we can. We need to go a step further and address certain populations, attend to their specific needs, and then watch their health outcomes get increased. Over 1 billion young adults are at risk of permanent, avoidable hearing loss due to unsafe listening practice. They say 1 billion people of young adults are at risk of hearing loss, not because it's genetic, not because they can avoid it, but because of unsafe listening practice. With this information, we know that, okay, if we can address the issue of unsafe listening practice, we can actually prevent about 1 billion people from experiencing hearing loss. So rather than wait for them, there's so many health conditions that are avoidable if we take a population health approach, because then we prevent what would cause it, what puts them at risk. So if we do a campaign, education, health promotion, health awareness, come up with systems and policies that enable self-listening practice, even if not all the 1 billion listen, but at least a good number, millions of young adults will be prevented from facing hearing loss. Now, I just want to go through some determinants of hearing loss and health outcomes. The first one is genetic factors, including hereditary and non-hereditary loss, hearing loss. And like I mentioned earlier, genetic factors are not ultimate. It's usually genetic factors in combination with other factors that then result in a health outcome. Intrauterine infections such as rubella and cytomegalovirus infection. These are things that, so if it's intrauterine, if we know we can address it before the baby is born, then we can mitigate the effects. Perinatal period, we have birth asphyxia, hyperbilirubinemia, low birth weight, and other perinatal morbidities and their management. Again, the awareness or the knowing that these conditions make people at risk of certain health outcomes, then we can pay more attention to people who go through this. So if there's better asphyxia during childbirth and labor, then we can know that, okay, we need to do certain tests, we need to take certain approaches so that we can either reduce the chances or completely eradicate the probabilities of this child growing up to face, hearing loss or problems with the ear, nose, and throat system. But if we don't address this determinant, we will continue to have an increasing number of avoidable health outcomes. Childhood and adolescence, chronic ear infections, collection of fluid in the ear, meningitis, and other infections. I think in the earlier presentation, there was a reference to someone who had meningitis and then went on to have ear loss. Knowing this, so whenever people have go through meningitis, again, I'm highlighting, we're not trying to, play God and prevent everything thing that should happen, but we can mitigate it. So if people have meningitis and then there is a follow-up because there is an awareness, remember, it is focusing on different population, addressing the different determinants to increase the health outcomes. Adulthood and older age, you have chronic diseases, smoking, otosclerosis, age-related sensorineural degeneration, and sudden sensorineural hearing loss. When we know people in this bracket, and then we can offer the health services that are relevant to improve their standard of living. The way technology is now, there is no medical diagnosis that is a final death sentence. There are always ways to improve the standard of living. Factors across lifespan impacted earwax, trauma to the ear or head. So someone goes through trauma, there's a traumatic, head injury. You don't just treat person and let go, knowing that, okay, this person can be prone to this. And then there's a follow-up. There is something happening to try to mitigate or to completely avoid the outcome when possible. Loud noise and loud sounds here would obviously involve other disciplines, policies and lawmakers. Ototoxic medicine, now we're involved with pharmaceutical department, work-related ototoxic chemicals, nutritional deficiencies, work-related don't involve quality controls, making sure that people who are working in certain environments are protected, from certain toxicity that comes from their place of work. Just making sure we're trying to reduce the determinant, trying to address the why. It's not just the outcome, trying to deal with the why so that the outcome can be influenced. Nutritional deficiencies, viral infections and other ear conditions, delayed onset or progressive genetic hearing loss. Now, what is the practical application to all this? As a doctor, you assess your patient's chart. Remember, we deal for population health and public health, it's going to be a lot of dealing with information you already have / gaining new information. So if you assess your patient chart, can you see a pattern? It could be based on age, it could be based on occupation. People in a specific field are coming with specific symptoms, similar symptoms. It could be based on geography, it could be based on sex or even lifestyle or income bracket or family size. Whatever it is, any pattern you see is more often than not random. Most experienced doctors have been doing this for a while unofficially. So you can go to a doctor and by reason of looking at your demographics and your symptoms can very easily make an intelligent guess as to why and what is going on. But what we're saying is, rather than it continue to be unofficial, let it be official. Let there be data collected. Let there be an outcome. Let there be a result. Let it be put together properly so that interventions can be put in place. Be deliberate, assess the data, get more if you must, collaborate with colleagues, collaborate with other hospitals, compare with data from other geographical settings, analyze that which you have. Once we can identify the determinants, what we can identify the whys, more than half the work is done. And then there is a gradual shift. Rather than waiting for people to get ill and treating them, we can address the determinant. We can address the why. We can get rid of the things that expose the people to certain outcomes. For those that cannot be avoided, we can mitigate the outcome, give them a high quality, and standard of living. And then we see that there is a shift. And 10, 20, 50 years from now, there would have been a drastic turnaround in the field and in the approach to medicine. Thank you very much. Does anyone have any questions?
If anyone have any questions, please feel free to ask. Hello, can you hear me? Anyone have any questions? Okay, then we will proceed to the next speaker. Thank you so much, doctor. I now take this immense pleasure of inviting Amir Malik Safi from Institute of Dental Sciences, India, to tell a talk on TB4 oral cancer. It is still unresectable. Hello,
Hello.
am I
Good
audible,
morning.
doctor?
Yes, yes, you are audible.
Okay, I can proceed now.
Shall I share my screen now? So good morning, everyone. The topic for today will be T4B oral cancer. Is it still unresectable? So before we will start, I would like to quote a famous saying by Baruch Spinoza. There is no hope unmingled with fear and no fear unmingled with hope. So to begin with, first we should know about the anatomy of the oral cavity. It is basically an anatomical cavity which extends from the skin vermilion junctions of the anterior lip to the junction of hard and soft palate posterior superiorly and to the line of circumvallate papillae posterior inferiorly. The various subsides of oral cavity includes the lip, anterior two-thirds of the tongue, buccal mucosa, floor of mouth, alveolus, RMT, and the palate. So what is oral cancer? It is basically a cancer which arises from any part of the oral cavity, and any ulcer or suspicious growth which persists for more than 3 weeks should give rise to the suspicion of cancer, and an oncologist opinion should be sought for the same. So to begin with the management part, first we should know how to stage the disease, and the most common staging classification used is the TNM classification, where T stands for the tumor size, and it ranges from T1 to T4 depending on the size of the tumor and the depth of invasion, whereas N stands for lymph nodal involvement, and it ranges from N1 to N3, N0 to N3, wherein N0 is no lymph nodal involvement present, and we further move from N0 to N3 depending on the number of lymph nodes involved, laterality of the lymph nodes involved, whether there is extranodal extension present or not. Then M stands for the metastasis, which means if the cancer has spread to the distant part of the body or not. So depending on the TNM classification, these tumors are staged into 4 separate groups. Stage 1 and stage 2 tumors belongs to the early stage tumors, whereas stage 3 and stage 4 tumors belongs to the advanced stage tumors. Also, before commencing the treatment of the patient, first we should determine the intent, whether we are offering the patient curative form of treatment or palliative form of treatment. Various treatment modalities for the management of oral cancer includes surgery, radiotherapy, chemotherapy, and combined modality treatment, wherein one modality is often combined with other modalities. So for oral cancer, surgery continues to be the cornerstone of the treatment, and various aspects are taken into account while choosing the treatment, such as stage of the disease and the performance status of the patient. Surgery is often used to treat the early stage cancer, and generally early stage cancers are best managed with single modality treatment, whereas for advanced stage tumors, multimodality treatment is required, and in multimodality treatment, generally surgery is followed by radiotherapy or chemoradiotherapy if we are offering the patient curative form of treatment. If we are giving the patient palliative treatment, then either radiotherapy alone or in combination with chemotherapy or chemotherapy alone can be offered to the patient. The choice of treatment will generally depend on the stage of the disease and the performance status of the patient. So AJCC staging system classifies the advanced T4 stage into T4A and T4B. And according to them, T4B is very advanced local disease in which tumor is invading masticator space, pterygoid plates, skull base, and or they encases the internal carotid artery. So most oftenly, masticator space and infratemporal fossa space are synonymous in clinical practice. However, the only difference is the involvement of the mesenteric space, which is present in the masticator space but absent in the infratemporal space. So the contents of infratemporal fossa space includes the muscles of the mastication, which includes medial pterygoid, lateral pterygoid, masseter, and the temporalis. Along with these muscles of mastication, ascending ramus of mandible is present, pterygoid plates, and few neurovascular bundles which are arranged in the multidimensional anatomy are also present in the infratemporal fossa space. So coming to the boundaries, the anterior wall is formed by the posterior surface of the maxilla. The posterior wall is formed by the tympanic plate and the styloid process. The medial wall is formed by the lateral pterygoid plate and the pharynx. The lateral wall is formed by the ramus of the mandible, and the roof is formed by the infratemporal surface of the sphenoid. So how the disease reaches to ITF? From the oral cavity, most commonly buccal mucosa and RMT lesions reaches to ITF. This is because they are in close proximity to the ITF and they can reach ITF by a direct extension. Apart from that, maxillary sinus tumors can reach the ITF through the posterior lateral wall of the maxillary sinus. Diseases from ITF can then reach to middle cranial fossa via various foramina such as foramen ovale and the pterygomaxillary fissure. So these ITF lesions are classified into supranotch disease or infranotch disease based on a horizontal line passing through the sigmoid notch. Disease which are limited to the disease which are limited to just below this line are termed as infranotch disease, and disease which are lying superior to this line are termed as supranotch disease. So another classification was given by Trivedi et al., in which class 1 stands for low ITF, in which only the medial pterygoid and masseteric muscles along with ramus of the mandible are involved. This corresponds to the infranotch disease. Class 2 or the intermediate ITF, in this there is involvement of lateral pterygoid and temporalis muscle and lower half of pterygoid plates along with involvement of the medial pterygoid and the masseter muscles. For class 3, it is also known as high ITF disease. There is involvement of the pterygomaxillary fissure and there might be intracranial extension as well. When we move from anterior-posteriorly, another classification was given in which compartment 1 corresponds to the low ITF disease with involvement of the masseter and medial pterygoid muscle, and there is no extension above the sigmoid notch. Compartment 2 or anterior high ITF, in this type of disease, the disease is limited to only the retroantral fat and there is no involvement of the muscles of the mastication. For compartment 3 or posterior high ITF, it is again classified into 3A, 3B and 3C, where in 3A, the disease is limited to the involvement of temporalis muscle and the paramandibular soft tissue. 3B is where disease is limited to the involvement of lateral pterygoid muscle, and 3C wherein extensive disease involvement is present and there is involvement of the pterygopalatine fossa and the pterygomaxillary fissure. So according to NCCN guidelines 2022, you can see the T4B disease was best managed with concurrent systemic therapy RT or induction therapy followed by RT or systemic therapy RT. There was no role of surgery in this, and these patients were best managed according to palliative intent. This concept has changed, and in a review article by Acharya et al., they have shown that tumors which are lying in the infranotch disease are generally resectable. And if the tumor has reached the lateral pterygoid muscle, which lies in the high ITF, will be technically non-resectable. So why these high ITF disease or T4B disease were deemed inoperable? It is because the complete removal of the tumor is very difficult. And this is because the anatomy of the ITF region is very complex and there are many complications to the surrounding areas. Also, the accurate assessment of disease spread is often limited by the tissue edema. And lastly, this area has a tendency to bleed heavily during surgery due to the presence of branches of internal maxillary artery and pterygoid venous plexus. So Trivedi et al. Have given a technique called as compartmental surgical approach, in which we try to remove the entire anatomic unit of the masticator space. According to them, achieving negative margins in all directions forms the basis of any surgical treatment and is the most important prognostic factor. And to achieve negative margins at depth is the most challenging part. So during this technique, dissection always follows in an anatomical plane. Hence, it is very easy and there is minimal bleeding. This is because we are going around the broader plane around the muscles rather than going through them. So in order to justify this, I would like to present a case series. So this is a case of right buccal mucosa in which there is orocutaneous fistula present, and Induration was present right till the infra-orbital region. This is the intraoral photograph showing right buccal mucosa region with involvement of the RMT as well. On imaging, we can see the anterior wall, the medial wall, and the posterolateral wall of the maxillary sinus were all involved, and the disease was eroding the ramus of the mandible and is reaching right till the coronoid and the condyle process. So these are the intraoperative photographs. We have taken the indurated area, and we have taken around 1 to 1.5 centimeter or margin all around. And we have done the surgery, and we have removed the entire specimen. The surgery performed was full thickness wide local excision along with segmental mandibulectomy and total maxillectomy and high infratemporal fossa clearance. The neck dissection done was modified radical neck dissection type 2, wherein we are preserving IJV and spinal accessory nerve. So this photograph clearly shows the structures present after clearing the infratemporal fossa. You can easily see the infratemporal surface of the greater wing of the sphenoid bone, the pterygomaxillary fissure, the foramen ovale, the roots of the pterygoid plate. As pterygoid plates we have removed, but we have roots of the pterygoid plate were visible. And also we have done total maxillectomy, so there was herniation of the orbital fat. On the medial side, we can see the nasal septum, as we have taken the lateral nasal wall along with the main specimen. So this is the resected specimen, wherein you can see the zygomatic arch, the orbital floor, the lateral nasal wall. So for the reconstruction of the infraorbital region, or for the reconstruction of orbital floor defect, fascia lata was used, which was harvested from the thigh. Further, the defect remaining after the removal of the disease was reconstructed with a bipedal PMMC flap, which was harvested from the chest region. This is the photograph showing the reconstructed defect. And this is the donor side, which was closed primarily. This is the photograph showing 18 months follow-up of the patient. So you can see these lesions are very much operable, and the patient is alive. So these are so we should justify the patients by giving them a meaningful life, and we should attempt by doing the surgery by giving a good infratemporal fossa clearance and allowing the patient to live peacefully. So another case in which we have, which was a case of CA right buccal mucosa again. There was orocutaneous fistula present. Again, we have done a high infratemporal fossa clearance along with full thickness cheek defect. And we have done again a total maxillectomy and a segmental mandibulectomy. Here, modified radical neck dissection type 3 was done, wherein we have preserved all three vital structures, namely the sternocleidomastoid, the IJV, and the spinal accessory nerve. Here in this photograph, you can again see that the floor of the orbit was reconstructed with the fascia lata, which was harvested from the thigh region. This is the photograph showing after the resection of the specimen. For reconstruction of this defect, we have used anterolateral thigh flap, which was harvested from the thigh region. This is the photograph showing reconstructed defect. This is the photograph after the suture removal of the patient. So another case which we are presenting is the again CA right buccal mucosa, wherein the disease was present right from angle of mouth till the RMT region. Herein again we have done an infratemporal fossa clearance along with partial maxillectomy and segmental mandibulectomy. Modified radical neck dissection type 3 was done, wherein we have preserved all three vital structures, namely spinal accessory nerve, the sternocleidomastoid muscle, and the internal jugular vein. This is the resected specimen, and we have reconstructed this defect by using anterolateral thigh flap. On the right side, you can see the harvested flap. And this is after reconstruction of the defect. This is how the patient looks. So the last case in which there was a CA present on the right side of the maxilla, and the disease was reaching right till the pterygoid plates. So we have performed the surgery and we have done infratemporal fossa clearance along with the distal segmental mandibulectomy and partial maxillectomy. This is the resected specimen, and this you can see the nice infratemporal fossa clearance. So this defect was reconstructed with a PMMC flap, and on the right side you can see the reconstructed defect. This is the final closure of the patient. So we'll review the literature on infratemporal fossa clearance. So a study done by Katna et al. On compartmental clearance of infratemporal fossa for T4B carcinoma. They concluded that T4B ITF clearance for T4B is a feasible option, and they have a comparable outcomes at locally advanced head and neck squamous cell carcinoma. And this technique provides a curative option for patients who were otherwise deemed palliative. Patil et al. Have done a study. What they have done is they have given neoadjuvant chemotherapy, and then they have done the surgery in very advanced, technically unresectable oral cancer, and they led to the conclusion that NACT led to successful resection and improved survival in significant portion of technically unresectable oral cancer patients. So again, they have done a surgery in which they have done ITF clearance. Study done by Badur et al. On surgical resection, whether it is justifiable for oral T4B squamous cell carcinoma with masticator space invasion. They conclude followed by adjuvant chemoradiation demonstrates a 24-month disease-specific survival of more than 50% and overall survival of 44%. And despite suboptimal margins, these modern surgical techniques have improved the ability to resect and potentially cure the patients with these tumors. So another study done by Patel et al. In which they have seen that primary surgical treatment in very advanced oral cavity carcinoma, they concluded that patients who underwent primary surgical treatment were associated with longer survival. So another study by Palatinkara et al. On clinicopathological characteristics and survival outcomes in oral cavity cancer with masticator space involvement. They concluded that surgically treated patients in the curative arm had significant survival advantage over the patients who had received only radiotherapy with or without chemotherapy. So coming to the question whether T4B is still unresectable, I think I have enough justified with my surgical photographs as well as with the literature that T4B is still resectable, and we should give every attempt to surgically resect these patients. And to conclude, surgery should be offered and preferred to all these patients with masticator space, pterygoid plates, or skull-based involvement, as radical intent treatment have good survival outcome, irrespective whether the disease is present in the infranose compartment or supranose compartment. Instead of offering these patients a palliative treatment, we should offer them a surgery. These are my references. Thank you. Any questions?
Thank you, doctor. Thank you so much for your presentation. If anyone have any questions, please feel to ask. Anyone have any questions? Okay, then we can go further to the next speaker. Thank you, doctor. Thank you so much for your presentation. Next, I would like to call upon Imran Bhatti, Liquid University of Medical and Health Sciences, Jamshoro, from Pakistan, to deliver his talk on complicated chronic supraortic otitis media and factors influencing the complications, including age. Hello, doctor. Am I audible? Hello. Please unmute the mic. Please mute the mic, doctor. We can't hear you.
Hello, Dr. Imran. You can start your presentation now. Please unmute yourself. We can't hear you actually. Hello, Dr. Let me know if you'll be able to present now. Uh, I will just wait for Dr. Imran for a few minutes more, and if he's available to present, then we'll be. Yeah, I can. We can see your video. Hello, Dr. Imran. We can't hear you. Please let us know if you'll be able to present us now, or else you would like to move to our next presentation. We are waiting for your response. Yeah, we can see your video now. He's not doctor. Hello, can you hear us?
Dr. Imran, we can't hear your voice.
Hello, Dr. Imran. Please unmute yourself. We are able to see the video, but we are unable to hear anything. Please connect your audio to the meeting.
Hello,
Yes, doctor, we can hear you.
hello.
Yes, we can hear you.
Hello, can you listen me?
Yes, doctor, we can hear you.
Okay. Actually, I have some got problem because of the should be because of the network. All right. I'm Dr. Muhammad Imran, and first of all, good evening to all of you from Pakistan. And I'm Dr. Muhammad Imran, working as a medical office, working as a senior registrar in the Department of ENT and Head and Neck Surgery at the Liaquat University of Medical and Health Science, Jamshoro. The topic of my study is the complicated chronic suppurative otitis media and the factor influencing the complication, including the age. This study was conducted in the one of the biggest hospital of the Pakistan, that is the Jinnah Postgraduate Medical Center, Karachi. The duration of my study is about 5 years, and it's a retrospective studies that is carried out in the Head and Neck Surgery Department of Jinnah Postgraduate Medical Center, Karachi. First of all, the chronic suppurative otitis media, it is the inflammation of the middle ear cleft characterized by ear discharge and permanent perforation. Though it has two types, atiquintal and tubotympanic. Atiquintal is dangerous because of the formation of cholestoma that cause the complications. So we have there is three pathway from the infection is spread. These are the just like from the boundaries, that is segment tympani up to the intracranial, and these the vein and piriform pathways. The sample of my study is that is was taken. The sample the 65 patients were carried out in the sample. And can you listen me? I didn't show anything from my screen, so might be you have to listen. Basically, this is means you have to know first of all the complication, that is intracranial and extracranial complication of mastoid. The extracranial complication mastoid is the mastoiditis, special palsy, labyrinthitis, and petrositis, while the intracranial complications are the meningitis, extradural abscess, subdural abscess, lateral sinus thrombophlebitis, and otitic hydrocephalus. The common pathway for the spread of infection is
Hello,
from
Dr.
the
Imran. Can you please share
yes.
the video? We can't see you.
Okay.
Yes.
You didn't show my ID. Have you listened me?
Yes, I'm listening. Please on the video.
Okay. Okay. I will just come.
Yes.
Have
Okay,
you
doctor.
listened?
Okay, doctor.
Okay. Basically, my topic of presentation is chronic suppurative otitis, complicated chronic suppurative otitis media, and the factor influencing the complication. I am Dr. Muhammad Imran Bhatti. Currently, I am working as a senior registrar in the Department of ENT and Head and Neck Surgery of Liaquat University of Medical and Health Science, Jamshoro, in Pakistan. The study was conducted in the Jinnah Postgraduate Medical Center. It is one of the largest hospital in the Pakistan where the study was conducted. The objective of my study is to study the frequency of complicated chronic suppurative otitis media and factor influencing the complication, including the age. First of all, I would like to introduce the chronic suppurative otitis media. Basically, chronic suppurative otitis media is a long-standing infection of the part or whole of the middle ear cleft, characterized by ear discharge and permanent perforation. Though it affects the both sexes and all age group, the common pathway for spread of infection that it may be spread through the direct gonorrhea or through the venous thrombophlebitis or piriform pathways. Basically, the complication of chronic otitis media are divided into two forms, that is the intracranial complication and extracranial complications. The intracranial complication are the meningitis, extradural abscess, subdural abscess, brain abscess, lateral sinus thrombophlebitis, while the extracranial complication are the mastocytitis, facial palsy, labyrinthitis, and petrositis. This is the patient that I have to collect the data from Jina Postgraduate Medical Center during my training of the post-graduation, and this is the different complicated cases that have to be shown in the picture. The pattern of my study, it's a retrospective study that is carried out in the ENT and head and neck surgery department of the Jina Postgraduate Medical Center, Karachi. The duration of study is 5 years, that is taken from the 2008 to 2030. Out of these 65 cases of CSOM with complication were evaluated, and we divide these 65 patients into group A that contain the age from 5 to 18 years and group B that contain the age from 18 to 45 years. Result of my study that there was 65 patients included in the study having complicated CSOM. Out of 66% were male and 34% is female. That is dominant in the male gender. Out of 65 patients, group A, that is 5 to 18 years, are affected 66.15, while group B, that is from 18 to 45 years, affected 33%. So it is usually occur in the younger age group. So significant association were found between the duration of complaint and family income is also related to the disease and age of the patient. So the lower is the age, greater will be the chance of getting the complication. So the low is the family income, greater will be the chance of developing the complication with the chronic otitis media. Out of 65 patients, that is 45 patients were developed the extracranial complication, while 20% patient would develop the complication of intracranial complication. Most common extracranial complication were studied is mastocytitis, that is from the 60% of the total number of the patient, followed by the facial nerve palsy, labyrinthitis, and petrositis. And most common intracranial complication were the meningitis that formed the 50% of the total study, followed by the extradural abscess, brain abscess, and lateral sinus thrombophlebitis. So the discussion of my study, there were 65 patients included in the study having the complicated chronic suppurative otitis media. Group A had 45 patients and group B had 21 patients. There was 42 males and 23 females. That is male predominance. Group A, that is the age of 5 to 18 years, affected 66%, while group B, age 18 to 45, was affected 33%. So the most common extracranial complication was mastocytitis, followed by the facial nerve weakness and labyrinthitis. And most common intracranial complication was the meningitis, followed by the brain abscess and extradural abscess. The complication occur in these patients because of there is organism virulence, poor resistance of the patient, systemic disease, and resistance to antibiotic. The patient also having the complaint in these complicated cases having belong to the poor socioeconomic status, lack of awareness about the healthcare, and lack of availability of the trained specialist. So let me conclude my study. The most of the patients were of the poor socioeconomic study, socioeconomic background with disease negligence, and there was delayed treatment. There is poor access to the health facilities, and there is improper use of antibiotic. This is the references that I have taken from the different studies for share here. And in the end, thank you so much for attention here. And any question you have to ask me about, any question from audience? Thank you so much.
Hello, doctor. Thank you for your presentation. Anyone have any questions?
Any question from from the audience?
Hello.
Hello.
Anyone have any questions? Okay, doctor. We will proceed with the next speaker. I call upon Mohammad Taha Mehdi Aragi from Sahid Beheshti University of Medical Sciences from Iran to deliver his talk on investigating the possible effect of oral magnesium on the improvement of sudden sensorineural hearing loss, a clinical trial study. Hello, Dr. Mohammad Taha.
Hello, everyone.
Can you hear me?
Yes, I hear you. Thank you so much.
Yes, doctor. You can proceed with your presentation.
Can I start now? In the name of God, the most compassionate, the most merciful. Hello, everybody. I am Dr. Taha Mehdi Aragi, Otolaryngology head and neck surgery from Shahid Beheshti Medical School. And today I am proud to be here on the clinical trial investigating the possible effect of oral magnesium in the improvement sudden sensorineural hearing loss. That we do this article in the Department of Otolaryngology, Shahid Beheshti University of Medical Science in Tehran. As you know, sudden sensorineural hearing loss is a rapid onset of subject hearing impairment over 72 hours or less, as 30 decibel or more over a period of 3 days, and at least a consecutive frequency with a specific or non-specific reason, or in some of the references as differences in hearing power of 10 decibel compared to opposite ear. In epidemiology, sudden sensorineural hearing loss affects 5 to 20 per 100,000 people in United States, and men and women are affected equally. Most commonly, it affects middle-aged people. In signs and symptoms, we or patient may report sudden objective hearing loss, ear fullness, tinnitus in one or both ears, and even vertigo. A specific cause of sudden sensorineural hearing loss may be infectious, such as syphilitis, vascular insult, trauma, autoimmune disease, internal auditory canal or cerebropontal angle neoplasm, acoustic trauma, ototoxic drugs, barotrauma, prelymphatic fistula, endolymphatic heat ropes, iatrogenic injury, and idiopathic. That's in this article. We surveyed the idiopathic reasons. In our physical exam, when we have a patient with sudden sensorineural hearing loss, we should do some physical exams such as complete head and neck examination, cranial nerve assessment, otoscopy for external and middle ear disorder, neurologic exam for central or systemic disorder, vestibular exam, and tuning fork test and fistula test for our evaluation. In the other evaluation, we maybe use imaging, but not for all of the patient. In some references, it advised to do MRI of brain with and without gadolinium to rule out retrocochlear or CP angle tumors. And in patient with a history of head trauma, to assess temporal bone fracture or normal labyrinthine that may cause sudden sensorineural hearing loss, we should do CT scan examination. In a laboratory test, routine ordering of a laboratory test in patient with unilateral idiopathic sudden sensorineural hearing loss is not recommendation, but in patient with fluctuating or by lateral sudden sensory neural hearing loss, we should do some lab tests such as RPR or FTA-ABS to rule out syphilitis, ESR to screen for inflammatory disorder, rheumatoid factors, anti-nuclear antibody, and other anti-neutrophil cytoplasmic antibody for autoimmune disorder, Lyme serology if risk factors are present, and thyroid function test, and glucose testing for diabetes mellitus. As you know, sudden sensory neural hearing loss is one of the ENT emergency, and approximately 85% of cases are considered idiopathic. And in many references, we don't know the exact cause of this disease. Sudden sensory neural hearing loss may resolve spontaneously in up to 65% of patients. And for therapy, we have some therapeutic protocols in references, systemic steroid, always best and most accepted treatment protocol. Intratympanic steroid, in our country we use this, intravenous and oral meglumine or antiviral drugs, anticoagulant drugs, vasodilators such as papaverine, nicotinic acid, anti-inflammatory drugs, and hyperbaric oxygen. And as you know, in many references, many of these therapeutic protocols have had limited benefits. And also until now, we have some limited in treatment of sudden sensory neural hearing loss. In our literature, we know that magnesium deficiency aggravates the ototoxic effect of drugs, and the exact mechanics of action of magnesium in hearing loss is not clear. We got two hypotheses. Magnesium is an antagonist of calcium, and as a result, prevent the release of the calcium. That this event prevents hair cells from being depleted of energy sources. And in other hypotheses, magnesium causes vasodilation of the arterioles of the inner ear, which prevent events related to the ear. This study was done as a double-blind clinical trial study that permitted by Department of ENT of Medicine of Shade PhD, University of Medical Science. And the trial followed the tenets of Declaration of Helsinki and all of the protocols of the study. And all the ethical protocols in the present study were approved by our ethics committee, and a study was conducted from April 2021 to February 2022 in ENT department of Otology Hospital in Tehran in Iran. And we record the demographic information of the patient, including age, gender, underlying disease in separate forms. Our inclusion criteria for the patient was definitive diagnosis of sudden sensory neural hearing loss based on our evaluation and our audiometric result of the patient. And our exclusion criteria include use of supplements containing magnesium in last 3 months in people, duration of illness more than 1 month, and contraindication of oral corticosteroid administration such as diabetes, hypertension, gastric ulcers, and duodenal ulcer, and presence of adrenal gland disease such as Cushing, or corticosteroid used to other diseases that may have a bad effect on our study. In presence of systemic infection or inflammatory disease, coagulation disorder, and the presence of other etiology of sudden deafness. Patient were randomly with block randomization method divided into 2 groups. Each group were 32 patients. In magnesium group received the standard treatment, prednisolone with the dose of 1 milligram per kg per day, and magnesium oxide with the dose of 250 milligram for 10 days as our initial therapy. And the placebo groups received prednisolone with the same dose and placebo. Our placebo was quite similar in shape and color of the magnesium oxide, with made of lactose that has not had effect in our study. And to make our study triple blind, the nurse, patient, and the analyzer were unaware of the group codes. During the study, patients' status was monitored by phone contact, and they were reminded of their regular consumption of the drugs. Patients were asked to return to the hospital for hearing evaluation in 10 days and 13 days of their treatment course, and audiometry was performed with the same person and same places, and the audiogram of the patient was re-evaluated. Our statistical analysis was done with using SPSS version 22 statistical software, and the data distribution was evaluated using a statistical test, Kolmogorov Semyorov. P-test was used to compare quantitative data, and chi-square statistical test was used to compare between two groups. And also we should note to this, the p-value less than 0.05 was considered statistically significant. In the current study, 64 patients were included in the study and were divided into two groups, and the average age of the patient was about 46 years old. The average age of the patient in the placebo group was 47, and the magnesium group patient was 45. There was no statistically significant difference between the two groups in item of age. In this table, the sex distribution and ear involvement in patient and placebo and magnesium group, you can see that there is no significant difference between the two groups in the terms of sex distribution and side of ear involvement based on chi-square statistical test. As you see this in the table, the magnesium group had 32 patients, and the placebo group are the same. Our male and female and ear involvement, right and left ear, and there is no significant difference between two groups and between the ear involvement between two groups of placebo and magnesium group. In this table, the level of improvement hearing loss in the right ear at 3 times in the day of 0, day 10 and 30, and can be seen both placebo and magnesium group show improvement over the past 3 days, because the both group has received the standard treatment, and no one had vanished from the treatment. Of course, the improvement in magnesium group, as you see in the table, was a better improvement than the placebo group. As you see in the placebo groups, we have a better improvement in the hearing loss. In magnesium group, better hearing loss, and in versus in placebo groups. And the p-value was significantly better. In table 3, as you see, which deals with the level of hearing loss in left ear at the 3 times, also in days 0, day 10, and 13 days after the start of treatment. As you see, the both control and the test group show improvement over the course of 3 days, but this is not a significant difference in both groups. And in this table 4, the level of hearing loss in magnesium and placebo group in general, without considering even left or right ear, we can see that both groups show improvement over time, but the magnesium group have a better improvement over the course of the treatment, and they have a better improvement. In our discussion, we see that in both group of patients receiving oral corticosteroid and placebo and receiving magnesium oxide showed and improvement in hearing status. This was in line with many previous studies showing spontaneous improvement over time. All of us know the exact mechanism of sudden sensorineural hearing loss is not clear for all of us, and also we don't treatment the patient, but may have a spontaneous improvement over time. That it is show us it is a complicated study for us. The healing process was better with intake of oral magnesium, and the amount of alternation in group receiving magnesium was in average 14 decibel improvement versus in the patient who didn't receive magnesium, just 10 decibel. And as we said above, magnesium deficiency caused the hearing condition to deteriorate the patient. Magnesium appears to act by vasodilation inner ear arterioles and preventing hearer cells from being depleted of energy sources. Another possible mechanism of that seems to be effective in result of magnesium consumption in the role of magnesium in controlling oxidative stress. We know that one of the hypotheses in sudden sensorineural hearing loss is oxidative stresses that make this happen. It's known that magnesium deficiency causes the effect of oxidative stress in the body to intensify. Since one of the most powerful theories related to sudden sensorineural hearing loss is oxidative stress, and this event increased free radicals that make the patient to a sudden sensorineural hearing loss. The patient who received oral magnesium had less oxidative stress and thus better improvement. The serum magnesium level in the patient was not checked before the start of the intervention, and it may have an effect on the result of our study. And few studies have investigated the effect of magnesium supplementation in improvement hearing in patients with sudden sensorineural hearing loss. And in one of the study in Nigeria and it's all in their study investigating the effect of magnesium in treatment of sudden sensorineural hearing loss, according to the result of their study in patients who received magnesium, but not oral in form of IV, intravenous form, the healing process was much higher than the patient in control group. And they recommended that magnesium is a safe and suitable adjunct to corticosteroid treatment for increasing the improvement in hearing, especially in the low tone frequency. The healing process was significant in patient receiving placebo and patient receiving magnesium. Oral magnesium along the oral corticosteroid had improved the hearing status of patient with sudden sensorineural hearing loss. And in order to make definite opinion, it is necessary to conduct detailed study on this thesis. And now, in our practice in our country, we administer oral magnesium with dose of 105 milligram per kg for people beside the corticosteroid, and we don't saw any complication, and the people tolerate with that very good. And I think we can use this supplement to healing better in sudden sensorineural hearing loss patient. Thanks for your attention, and this is my email, and any question you have in our databases or in the process of this study, it's my pleasure to respond to you. And I want to thank the manager of this great Congress to let us participate in this. Thanks for your attention.
Thank you so much for your presentation, Doctor. If anyone have any
Thank you
questions,
so much.
please feel to ask. Anyone have any questions?
Thanks again.
Doctor? Hello, Dr. Amir. Can I hear you?
Hello, hello.
Yes, you can proceed now.
Can you see my slides?
Yes, doctor, we can see your slides.
Perfect. Thank you. Thank you for inviting me. I'm Amir. I'm a junior surgical trainee in ENT surgery based at Cambridge Hospital in England. So I'm going to be talking today about a systematic review and meta-analysis that we did looking at telehealth options in managing the consequences of tinnitus. So, as I'm sure most of you know, tinnitus is a very complex symptom and it's quite poorly understood. It's a heterogeneous disorder that causes a phantom sound in the ear to be experienced by the patient without any external stimulus. It's very common in the UK. 7 million people suffer from it. So that's roughly 10 to 15% of the population. And lots of people experience severe impacts on their quality of life, a further 10 to 15% of that group. This can be a consequence of tinnitus affecting their hearing, but also their sleep as well as thought processing. The current NICE, we call them NICE guidance, National Institute of Health and Care Excellence guidance for treating them in the UK, treating tinnitus, is to either use amplification devices or tinnitus-related cognitive behavioral therapy. So those are the two mainstay treatments for tinnitus-associated distress, but nothing else is documented or advised at the moment. So in recent years, there's been a growing interest in the use of internet as well as smartphone-based technologies in healthcare. And this has obviously been emphasized by COVID and the pandemic that we had, where we were trying to limit the number of face-to-face interventions with patients to ultimately limit the spread of the coronavirus. So the ability to provide necessary audiology services is also problematic worldwide because there is a shortage of these services, and internet or smartphone-based options may offer a very attractive solution to this. But there is a big need for more studies to ascertain whether there is a true benefit of telemedicine techniques in treating tinnitus. So the aims of this study were to review the literature on comparing telemedicine therapy options to conventional in-person options in the management of primary subjective tinnitus, statistically analyze the impacts each of these have on the burden of tinnitus experienced by the individuals. And then secondary outcomes we looked at were common comorbidities such as anxiety, depression, insomnia, as well as the quality of life experienced by the patients. We wanted to identify the benefits and challenges of different therapeutic modalities in targeting tinnitus in the long term. So the study was registered with Prospero and conducted according to the PRISMA guidelines for systematic reviews and meta-analyses. We did a literature search of abstracts as recent as February 22. So everything up to February 22 in PubMed, Embase, Cochrane Library, Google Scholar, Scopus, Web of Science. So quite a few different sources of abstracts. And then we also scanned references for linked studies of individual papers. We use this search term to look for the abstracts. So looking at tinnitus, smartphone, mobile telephone, etc. So just to make sure that we can get as many papers as possible. So what did we include? So we included randomized control trials that were specifically in English, human participants only that had a diagnosis of chronic primary subjective tinnitus. We looked at all methods of telemedicine approaches, so that's mobile, internet, telephone, and books to manage their tinnitus. And we looked at all types of controls. Okay, so that included face-to-face controls, that included waiting list controls, as well as hybrid delayed intervention controls. And we only used studies that used a questionnaire with quantitative scores to measure outcomes or measure the progression of disease. So that was really important. We used Cochrane's collaboration tool for assessing risk of bias, and that was done by 2 reviewers. And then if there was any discrepancy, a 3rd reviewer would get involved. And then the abstracts were also screened by 2 separate authors. And then in any cases of discrepancy, the 3rd author was involved. We had baseline characteristics that included country of location of study, age, tinnitus, duration, as well as gender split were extracted from the data. The study arms type of randomized controlled trial, attrition rates, mean and standardized deviation of tinnitus burden scores before and after a period of time for both the intervention and control groups were also extracted, as these were important to process. The extracted scores were aimed to be kept as consistent as possible in terms of the type of questionnaires that they were using, so that we could conduct a more thorough meta-analysis. We also looked at long-term primary outcomes, and this was for data that was reported for more than 6 months follow-up. Secondary outcomes such as anxiety, depression, insomnia, and quality of life scores were also extracted from the studies, just because these are very common comorbidities. The data was analyzed using the Cochrane Review Manager, RevMan, version 5.1.0.9, if anyone's interested. So the basis of the statistics, so we had a random effects model that used or looked at standardized mean differences that were between the intervention and control groups, and it used a Cochrane's formula for imputing standard deviations where this was not reported, using correlation coefficients that were calculated from a study that was identified as being very rigorous in their reporting. And this is mentioned in our references. So Henry et al. Was, of all the included studies, was the most rigorously reported. And we could use that to impute standard deviations and allow the random effects model to work with standardized mean differences. And this, again, I will reiterate, this was made possible by the fact that we made sure that the data was as close to each other as possible in terms of the type of measurement scale, the interval between baseline and post-intervention, as well as similar populations involved. We used a Z statistic that to measure the statistical significance of the summary effect size. Heterogeneity was also looked at, and that was calculated relating to the effect sizes using Cochrane's Q statistic with a significance level of 0.05, as well as an I-squared index. We used funnel plots to investigate for publication bias, but this was only done by visual inspection and nothing else. So for secondary outcomes, Cochrane's imputation method was not possible for anxiety and depression, unfortunately, because these weren't rigorously reported in our or the study that we used for the other ones, so Henry et al. And so insomnia and quality of life outcomes were also, so for anxiety and depression, Cochrane's imputation method was possible, but for insomnia and quality of life, they weren't possible, as Henry et al. Was substandard in their reporting, so we couldn't use the Cochrane's imputation method. So when we excluded the high risk of bias studies, a score was calculated based on the Cochrane's collaboration tool, and we assigned 1 point for each low risk, 0 points for each unclear risk, and -1 for every high risk. And then studies with a score of less than or equal to 2 points were regarded as having a high bias. Yes, and were excluded in one stage for the meta-analysis. Where there was any high heterogeneity, a subgroup analysis was also performed to see if potential outlying studies could be excluded from the meta-analysis and how it impacted the results. So this is just a Prisma diagram to show the flowchart of the study. So we started off with 2,297 articles that were identified across all these databases. After removing for duplicates, we're down to 1,894. And then, can you see my pointer? Sorry, I don't know if you can see my pointer. Maybe it's and then after we removed for title, after we screened for the title and abstract, we were down to 24 studies, and then it's gradually filtering out until we could only include 10 in our quantitative analysis. So the forest plots were produced with RevMan. And so this is the first forest plot that I want to bring to your attention that compares telemedicine-based interventions of any type to a control, and that's to any type control as well, that whether that be face-to-face, waiting list, or weekly discussions. And this was looking at tinnitus burden, which was our primary outcome. And as you can see here, based on the forest plot, it does favor the telemedicine techniques, as noted here, and this was statistically significant. But it is very important to note that there is a very high heterogeneity, with it being 88%. But I mean, this is to be explained as, although we've tried to keep the studies as similar as possible, the differences in the slight differences in measurement scales, patient population sizes will bring this number up, as well as the type of controls they've used. And when you looked at the visual inspection, it was roughly symmetrical, suggesting that there was no sort of clear publication bias. So this is another forest plot that we did that showed the effect sizes of studies comparing telemedicine-based interventions of to face-to-face controls. And this was again looking at tinnitus burden as the primary outcome, but we've focused on just face-to-face controls. So as you can see, when you reduce or you remove some of the other types of controls, the heterogeneity does go down, albeit it's still a bit moderately heterogeneous, but it has been reduced. Unfortunately, it does favor the face-to-face options in managing managing tinnitus or burden of tinnitus when compared to telemedicine. And this could be explained by the fact that patients feel a bit more involved in their treatment when they see a person or an audiologist face-to-face and are having sort of that interaction with them. But again, important to note that this is statistically insignificant, whereas the previous one was statistically significant. But visual inspection suggests that there's no sort of visual, there's no publication bias, as it's roughly symmetrical, but ideally this would be done with more studies. This was a subgroup analysis that compared telemedicine-based interventions of any type to all the controls, but we're looking at tinnitus burden as the primary outcome again, but we've removed all the studies that were higher risk of bias as per the calculations we mentioned in our methodology. So that would leave only 3 studies that weren't as high risk, that didn't have a high risk of bias, and that's less heterogeneous than previously. And it does favor the telemedicine approaches now, although this is statistically insignificant. So it suggests that there may be a benefit to telemedicine, although it's statistically insignificant. This is another forest plot that showed or compared the telemedicine-based interventions of any type to a passive control, so not face-to-face controls. So that's waiting list and weekly discussion forums or delayed intervention. So this is again looking at tinnitus burden as the primary outcome. And we've removed the studies that account for high statistical heterogeneity. So obviously when you do that, so these are the more similar studies, you get a hugely reduced I-squared or heterogeneity index, so 21%. So the studies are quite similar together. And it does hugely favor telemedicine approaches, suggesting that there is a benefit to telemedicine versus all types of controls. And it is statistically significant when you remove the high heterogeneity studies. Forest plot here is comparing telemedicine-based interventions of any type to, again, any control that we had. And we're looking at tinnitus burden, again, as the primary outcome. But we've looked at just the long-term follow-up data, as opposed to previously where it was the more short-term data. And so when we looked at long-term, again, the studies were very heterogeneous in their way of reporting long-term, as suggested by this high I-squared number of 91%. And there was no sort of real benefit of using telemedicine approaches over long-term, the controls, so face-to-face waiting list or weekly discussion. And I think this is more to do with the fact that the telemedicine approaches were only being used for the period of the study. And as soon as the study ends, they stop having that interaction with the telemedicine approaches. Whereas actually the benefit of telemedicine is that the patient can continuously use it. So there shouldn't be a defined period of time where they're using it. But obviously, I hope you can appreciate with the studies and the way that they're set up to make them as fair as possible, there needs to be a defined study period. So this is a forest plot that we did that compared telemedicine-based interventions of any type, again, to any control that was included in amongst the 10 studies. But then we've looked at the secondary outcomes now. So we're looking at anxiety, and we were only able to look at the ones that had comparisons at 6 to 12 months follow-ups. So this meant that only 4 studies met that criteria, and is not that heterogeneous, which is quite good, suggesting the studies are quite similar to each other, or the spread of data is quite similar to each other, sorry. And that when we've tested for the overall effect, it suggests that it could favor the telemedicine approaches in reducing anxiety scores, although this is statistically not significant, but suggests that there may be a benefit in improving anxiety scores. This is looking at depression, so similar to the last one, but looking at depression. Again, the data is not very heterogeneous, which is good for our processing, and it suggests that there may be a benefit in reducing depression scores, although again, this is not statistically significant. And then this one looked at insomnia as a secondary outcome. And if you remember, insomnia had to be processed differently as it was substandard reporting in Henry et al.'s study. And when we did this, we were able to show that there was absolutely no heterogeneity amongst the data, which is great for the processing. And it did statistically favor telemedicine. So this is comparing the post-intervention scores, so post having telemedicine, to the baseline. And I agree, it's not the most rigorous processing of data, because you can argue that having any intervention could sort of risk placebo bias. But this is what we were able to deduce from the data, that actually having a telemedicine approach favored the what was favorable in terms of reducing insomnia scores, and this was statistically significant. And this looked at quality of life, which was again had to be processed slightly differently, and actually it had no real benefit on changing quality of life in the studies that were included. So just a bit of a discussion around the data I've just presented to you. So this systematic review and meta-analysis that we conducted is the first to our knowledge that evaluated all the randomized controlled trials comparing telemedicine approaches to conventional measures in reducing tinnitus burden in isolation, as opposed to grouping with vestibular and hearing disorders. So in the past, a lot of the, well, there's only been, to our knowledge, a couple of systematic reviews and only one meta-analysis, but they grouped a lot of different disorders together, as opposed to just focusing on tinnitus. Many previous studies never truly compared controls to controls, but we've tried to do that as much as possible throughout our meta-analysis. They focused on just doing time point differences, which is what I was trying to explain with insomnia and quality of life. We ended up having to do that for just insomnia and quality of life, the secondary outcomes. 11 studies met the inclusion criteria, but only 10 studies were available for quantitative analysis, and this consisted of 1,194 adult participants. They highlighted three main methods of telemedicine interventions, which were internet-based CBT. Internet-based CBT was the most popular, N equals 9, followed by one telephone-based therapy and one self-help book. So as you can see here, there's actually no smartphone, no RCTs looked at smartphones, which is disappointing because you'd hope that smartphones would be a very attractive way of providing telemedicine or tele-treatment for tinnitus. But that's the reason for this, is because the RCTs that were found for smartphones were not published yet. So they are currently in the works. The data presented by the 11 studies were very heterogeneous, and we talked about the reasons for that, just because of the varying number of participants, types of interventions and controls compared against, as well as the way of reporting the primary outcome. And even though we tried to keep them as similar as possible, it is difficult to do that. Visual inspection of funnel plots that indicated that the variance was about the same because of the symmetrical distribution, suggesting that there's no obvious publication bias, but ideally this will be done with more studies. So there is a lot of agreement in the literature. So Hoare et al. Were able to report significant benefit to tinnitus symptoms when using internet-based CBT, which we agree that there may be a benefit to using it. Similarly, Bukes et al. Were able to demonstrate increased effect size for internet-based interventions in managing tinnitus burden when compared to the effect size for control groups as well. The follow-up is very crucial in a symptom such as tinnitus, where you have life, essentially some people have it for life, and it's lifelong burden of disease. So it's very important to look at follow-up, because it's our hope that an intervention will be able to suppress that burden of disease over a longer period of time. But Henry et al. Was actually the only study that statistically significantly reduced tinnitus burden in the follow-up data. And we talked again about why that would be, because there's a defined period of time where the intervention period is, or the intervention is being given to the patient, whereas ideally we'd like patients to have unlimited access to the telemedicine approach. And that's the benefit of having a telemedicine option, that they can just access it whenever they want, and there's no limits to that because of resources such as limited audiology clinics or the pressures on healthcare systems. It's difficult to assess effectiveness of telemedicine options because the studies limit usage to study periods. This is what we were just saying. Depression and anxiety have been shown to have a strong association with tinnitus, whereby the severity of tinnitus is related to the likelihood of developing these comorbidities. And this is somewhat suggested by our studies. And again, Hesser et al. And Hoare et al. Were able to agree that CBT improved both anxiety and depression, internet-based CBT. Reducing tinnitus in these participants may indirectly contribute to reduction in anxiety and depression scores, but it is likely that these diagnoses will require prolonged periods of tinnitus treatment, as they're much more complex comorbidities, and maybe other focused talking therapies targeted at depression and anxiety. But we suggested that there may be an effect of floor effects, or floor effects could explain the changes in depression and anxiety in these randomized controlled trials, just because of a low baseline score. So any sort of minor effect will be exaggerated in the statistical analysis, and the more distressed individuals are more likely, the more distressed individuals are less likely to opt into a clinical trial, for example, and that can skew the results. Bukes et al. Also found insomnia to be statistically significant, reduced by internet-based interventions, which agrees with our study. Quality of life becomes, again, a very important measure to consider because tinnitus is associated with a poorer quality of life. Bukes et al. Also showed no real impact on quality of life, which agrees with our study. Limitations of our study included reporting of outcomes not consistent, as even though we tried to keep it as close to each other as possible. It is difficult. There's also this problem of clinically significant versus statistically significant reported data. And ideally, we'd want clinically significant results because we're trying to achieve a clinically significant outcome in our patients. Cochrane's imputation method, although it is a very rigorous and well-documented method, does have its own limitations. Ideally, all the data would be presented in a similar fashion to allow a streamlined way of processing the data, but we had to use this method of forming a coefficient based on a well-reported study. The number of studies included in the quantitative analysis is 10. Not the worst, but not the best. So ideally, we'd have more in a quantitative analysis, but that is the limitation of doing it on such a niche topic. Cognitive flexibility wasn't standardized in 2 studies, so we need to be able to adjust for a patient's ability to deal with smartphone or internet-based options. Because if they're not able to comply with these options, then they're going to struggle and probably skew the results. So conclusions: tinnitus is a complex pathophysiology that, under our guidance in the UK, is managed with mainly tinnitus-related cognitive behavioral therapy delivered by audiologists. The literature is limited to systematic reviews on one type of therapy, as per the above, in-person treatments, and limited to inclusion of studies due to when the studies were done. So a meta-analysis had not been performed before on existing literature surrounding all telemedicine options and tinnitus treatment, focusing on higher quality studies such as RCTs. We've included 11 RCTs and 9 looked at internet-based CBT. A Z value of 9.87, statistically significant and low heterogeneity, revealed telemedicine approaches may be better at reducing tinnitus burden compared to passive controls. When looking at insomnia, again, they suggested that telemedicine options may be effective at reducing insomnia burden. However, quality of life showed no real improvement. Unfortunately, there is ongoing need to improve the quality of research conducted in tinnitus, despite previous efforts in improving standardized research protocols in tinnitus studies. Thank you very much for listening. These are my references. Do you have any questions at all?
Thanks for your presentation. Anyone have any questions? Hello. Hello, am I audible?
Yeah, you're audible.
Okay. Okay, thank you, doctor. Thanks for your presentation.
Thank you.
Let's take a short break, 10 minutes. Please don't leave the room. Again, we will start this session. After 10 minutes, sharply, you can join the session. Hello. Welcome back to all. Are you there, doctors? Hello.
Yes, hello.
Yes, doctor. Now I would like to invite Fatima Hafsa from University of Kelaniya, Sri Lanka, to deliver a talk on parent-reported emotional well-being, challenges and expectations on hearing aid usage in children aged between birth to 15 years from a selected audiology clinic.
Am I audible?
Yes, doctor.
Greetings and hello everyone. I'm so grateful and glad that I'm able to present my research at one of the best conferences, and this is my first international conference. My heartfelt gratitude to the organizing committee for giving me this wonderful opportunity. I am Fatima Hafsa, a final year undergraduate student of Seton Hearing Science, specialized in audiology at Faculty of Medicine, University of Sri Lanka. Also, I would like to thank my mentor and supervisor, Ms. Dominique Silva, who is a senior audiologist and senior lecturer at Faculty of Medicine. Today, I'll be presenting on parent-reported emotional well-being
Can you please raise the voice?
challenges and expectation on hearing aid usage in children aged between birth to 15 years from a selected audiology clinic, Sri Lanka. To start, sense of hearing plays a crucial role in early childhood as it provides the foundation for speech and communication skills. Thus, undetected or delayed identification of hearing loss negatively impacts the child's personal, social, and educational development. World Health Organization 2018 reports that approximately 32 million children presented with disabling hearing loss across the globe. An estimation indicates that the most of them are in developing regions of South Asia, Asia Pacific, and Sub-Saharan Africa. The number of children affected by hearing loss indicates the necessity of implementing an early and effective intervention to diminish any adverse effects for children with hearing loss. The development of language skills in children with hearing loss is similar to normal hearing peers, only achievable by receiving adequate treatment. Surgical or pharmaceutical interventions restore hearing in few cases with hearing loss, while majority of other people with hearing loss benefit from hearing aids that amplify sounds to compensate for hearing loss. Children with hearing loss need to access a full range of speech sounds during all waking hours. Hence, parents play a significant role in the intervention process by encouraging regular hearing aid usage, which is considered an essential component of effective intervention. However, parents may encounter a range of challenges related to hearing aid management, as most of the parents are having normal hearing and the and need to manage hearing aids are unfamiliar experience to them. Almost nearly all the families are stressed and doubtful about the initial diagnosis and intervention process. Audiologists have crucial role in providing informational and emotional support to the parents related to their child's hearing loss. Effective management that leads to language development is achievable by making the parents understand several key aspects. In Sri Lanka, the newborn hearing screening program is implemented in a few private hospitals. And in the government sector, screening is done only in babies with identifiable risk factors like prematurity, birth asphyxia, neonatal jaundice, and so on. Previous studies found out that even though the hearing loss gets identified earlier in children, there seems to be a delay in the intervention process, and various factors contribute to the delay. Joint Committee on Infant Hearing 2007 guidelines recommends that the children should be fitted with an amplification device within 1 month after diagnosis of hearing loss. Professionals involved in hearing health care need to understand these factors to encourage early identification and intervention, because the earlier the intervention will result in improved developmental outcomes. A systematic review study done between 1980 and 2012 reports that only a few research has been done about hearing aid use in young children, and there is necessity to conduct future researches on parent factors, multiple disabilities, and cultural differences, how influence on hearing aid use, quality of hearing aid fitting, and to investigate effective strategies for increasing hearing aid use. Studies done on psychosocial experiences of parents who have children with hearing loss over the years suggest varying results, with some showing higher stress levels for parents of children with hearing loss than parents with normal hearing children, whereas others show no significant delay between two groups. According to Plotkin 2013, parents of children with hearing loss experience elevated level of stress because of some unique circumstances emerged with the raising child with hearing loss. Also, the study reveals that the parental personal traits significantly impact on parenting stress and child's overall outcome, but may not consistently impact throughout the child's development period. Cousin and Aum 2020 reported that majority of parents of children with hearing loss functioning similarly or better than the parents of children with normal hearing. Also, the study reveals that there is no association between children's age, aged services received, and parent psychosocial functioning. It is important to identify parent psychosocial experiences because parents' emotional factors also influence on regular hearing aid management. The existing literature do not indicate any parent-reported challenges of hearing aid usage in children in Sri Lankan context. Therefore, I tried to describe firstly the reasons for the delay in hearing aid fitting in children aged between birth to 15 years. Secondly, to identify parent expectation on audiology support for hearing aid management. Thirdly, to identify activities and situations which influence on consistent use of hearing aids. Finally, to compare the emotional well-being of parents of pediatric hearing aid users with the age of the child, the caregiver age, and duration of hearing aid use hours per day. For this, I have selected the Audiology Clinic of University of California and recruited all the parents of registered children aged between birth to 15 years who have received hearing aids or reported to use hearing aids from Audiology Clinic, Faculty of Medicine, University of California. There were 76 children according to the clinical records on 1st of August 2022. I have excluded the parents the parents of children who have upgraded to implantable devices, and there were 42 children, parents responses were included in the analysis. For the data collection, interviewer administered 2 questionnaires via telephone call were used. The developed questionnaire was used to measure used to understand parents' experiences on hearing aid management. It includes close-ended questions with a 5-point Likert scale and open-ended question. This questionnaire consists of 4 sections. The other questionnaire was Parental Stress Scale, abbreviated as PSS. Translated and validated singular version of the PSS was used to measure the stress level of parents. PSS is an 18-item questionnaire which considers both positive parenthood, like emotional benefits, personal development, and negative aspects of parenthood, like demands on resources and restrictions. Overall, possible scores will range from range between 18 to 90, and the higher the score, the higher the parental stress level. The developed questionnaire was given to the 5 audiologists working in pediatric audiology and hearing aid dispensing to obtain content validity. The experts were asked to rate 40 questions on a Likert scale, include 1, which is strongly agreed to, 5, which is strongly disagreed. The content validity index was calculated, which shows 0.79. The validated questionnaire by experts were administered on 2 parents and asked to provide suggestions. Minor alterations were made based on the feedback provided by the experts and the parents. Data was analyzed using statistical package for the social sciences software version 26.4 descriptive statistics. Spearman correlation test was used to identify the relationship between child age, parent age, and parental stress level. Independent samples through playlist test was used to identify the relationship between child's hearing aid use hours and parental stress level. The data of open-ended questions were analyzed using conceptual content analysis. 95% of respondents considered themselves as having normal hearing in both ears with no prior experience in hearing theater disorder. Geographically, respondents represented 11 districts of the country. Children were with an average age of 9 years at the time of study. 16 caregivers reported that their children have additional disabilities, representing 38% of the sample. While considering aspects of hearing loss identification and intervention, the study revealed majority of children do not undergo newborn hearing screening and completed the diagnostic hearing test within first year of life, but fitted with an hearing aid within first 1 to 2 years of life. Majority of children uses hearing aid for 1 year, but recommended from professionals for both years. Within hearing aid users, 33% of children recommended for cochlear implantation. As expected, more than half of the participants, which is 64% of children, had to experience delay in hearing aid fitting. The delay between hearing loss diagnosis and the hearing aid fitting ranged between 0 to 36 months, with median age of 8.06 months. Identified main causes were financial difficulties and long waited and requires of additional appointments. Some other identified causes were unavailability of audiologists in the area, COVID-19 pandemic, confusion between cochlear implantation and hearing aids, unavailability of appropriate hearing aid, and not advised to fit hearing aid after hearing test. This graph shows how many appointments between diagnosis and the hearing aid. The crucial period for learning syntax is the first year of life. Initial language learning requires a neurologically occupied mind and enough language. Though most of the children were identified with hearing loss in their critical period of language acquisition, but the age of hearing aid average age of fitting was 47 months. Thus, identification of hearing loss as well as the hearing aid fitting showed significant delay according to the guidelines of Joint Committee Infant Hearing. The year 2013 discovered that fitting, loan hearing aids, and purchasing hearing aids through private insurance were 2 strategies to ease the financial strain of getting hearing aids. Jobela 2016 suggests that flexibility in scheduling appointments and availability of return appointments are essential for centers choosing to serve the pediatric population. also indicated that failure to follow a systematic approach in hearing aid fitting will likely result required of additional appointments and difficulties associated with written visits for hearing aid fitting. When considering audiologist support on hearing aid management, emotional support from professionals is essential as majority of parents have normal hearing. 85% of parents reported that they received adequate emotional support from audiology, while 6% reported they did not receive the adequate emotional support. For the consistent and effective hearing aid use, some critical information from audiologists were necessary. The results indicate that all the parents received clear information about cleaning and maintenance process of hearing aids. However, only 57% of parents have received an explanation on importance of consistent use of hearing aids. 41% of parents reported that they were not informed about available X-ray. Also, 64% of parents were not aware of what can hear and cannot hear from the child's hearing aid. More than half of the participants did not receive information on how to conduct daily listening checkup. Majority of parents, which means 69% of parents reported they were not taught any strategies to keep the hearing aids on their child. Follow-up appointments for fine adjustment in hearing aids is important. However, appropriately, half of the parents visited only 1 to 2 times after hearing aid fitting. This may indicate that complaint of increased loudness from hearing aids in children in 14%, which interfere with consistent hearing use. The parents reported that their child never used hearing aids while playing outside in 47% and outing in 45%. Other situations that interfered with consistent hearing aid use were dislike to wear hearing aids, fear of losing hearing aids, and not convinced with benefits of hearing aids. The reasons behind the low usage of hearing aids may be while playing outside and outing could be parents' fear of losing hearing aids. There may be a relationship between recommended hearing aids used by the professionals and the benefits of hearing aids in children. In this study sample, 62% of children used hearing aids in only 1 year, but the professionals recommended for both years in 81% of children. Among them, 36% has been recommended for cochlear implantation. However, 52% of children uses hearing aids all working hours, reported by parents. Considering the emotional well-being of parents, in this study, parental stress scores range from 25 to 70, with a median score of 28. But there is no cutoff scores for Sri Lankan population for PSL, so the scores could not be interpreted. Also, at this time, not clearly identified, parental stress is purely from having children with hearing loss, as many factors influence on parental stress. But at initial stage of identification of hearing loss or hearing acuity, almost every parent reported that they find it hard and stressful, and slowly adapted and accepted. General stresses including unemployment or economic difficulties, as well as family stresses including divorce or family conflict, can elevate parental stress levels. And Godemuna 2014 reported that the development of effective coping strategy in parents is essential interventions for parents of children with developmental disabilities in Sri Lanka. The present study investigated the relationship between child age, caregiver age, and parental stress level. The study reveals that there is no correlation between child's age, parent age, and parental stress level. But in contrast, a study found out that compared to parents of younger children, parents of older children may experience higher stress. And older mothers tend to report greater distress level related to medical and legal concerns for the child. Also, the present study investigated the parental stress level and child's hearing aid use hours. There is no correlation found between parental stress level and child's hearing aid use hours in a day. But in contrast, Munaz et al. 2015 found depression was causing their ability to manage to be somewhat or very difficult, and non-statistically significant correlation for depression and parent-reported hearing issues. The study has some limitations and its scope include the study sample involves only Sinhala-speaking parents, as identified participants from selected audiology clinic were all native Sinhala-speaking parents. In a recent study, Caballero 2017 surveyed parents of Hispanic families in the United States and discovered that 47% of families required assistance to communicate with an audiologist. Those, including Tamil-speaking parents, might reveal some other challenges where audiologists should focus. A study found out through hearing aid data logging, the parents overestimated the duration of hearing aid usage by an average 2.6 hours to as much as 10 hours in children. Thus, for appropriate hearing aid use hours can be measured by objective measures like data logging. Also, future research should focus on explore the challenges of hearing aid management in young children with diverse backgrounds. Using a qualitative or mixed method study to understand associated factors and experience in them. In conclusion, in the study, more than half of the study sample had to experience a delay in hearing aid fitting. Secondly, parents required comprehensive information on hearing loss and hearing aid management. Also, no correlation found between parental stress level, child's age, hearing aid use hours, and caregiver age. Finally, audiologists have the role of understanding parents' experiences and challenges as well as considering their emotional well-being to support and provide family-centered care. Thank you very much. Hello.
Hello.
Yeah.
Thank you so much, Doctor, for your presentation. Let's take a lunch break, 20 minutes. After that, we will again start the session. Please don't leave the room.
Really mute.
Hello, Dr. Reham.
Hello.
Hello. Hello, am I audible?
I think it's time to start.
Yes, Dr. Yes.
Yes.
It all are there.
You can see me now.
Yes, yes. I think after 5 minutes we can start the meeting.
Yes.
After 5 minutes we can start the meeting.
Yes. I can't hear you.
After 5 minutes we can start the meeting.
After what?
5 minutes.
5 minutes? Okay.
Yes, Doctor. Yes. Did all are there, doctors? Can you hear me? Hello. Hello, Reham. Hello, doctor.
Hello. Yes, hello.
Yes, yes, yes. Did all came?
Yes. Yes, start now.
Yes, doctor. 1 minute. Did all came? Hello, doctors.
Yes.
Are you there
Start
here?
now. Yes.
Okay. I call upon Raham Jatun from Port Said University from Egypt to deliver
For Said, Egypt.
Port Said University, Egypt to deliver her talk on allergic rhinitis, patients associated with migraine, effect of treatment of allergic rhinitis on migraneous attack.
Your internet connection is unstable. Only Karen is Only Karen is free. كارين ومحمد. اطفي النت يا كارين انت ويوحنا. اطفوا النت انت ويوحنا. Hello?
Hello, doctor. You can proceed now.
Yes, you hear me?
Yes, yes.
And see me? You see me? Hmm?
Yes, doctor. You can speak out.
Hmm? تعالي اعمل لي شير كده. اوكي. طب انا مش باين الشير. Hello. Good afternoon, everybody. I would like to thank you for calling me here for this conference. And I would like to thank you for this good talks yesterday and today. I am Riham Farouk Zatoun. I am Assistant Professor of Otolaryngology in Port Said, Egypt. I am interested in headache and migraine attacks because we see a lot of patients with which has migraine and which have a headache, and usually diagnosed as sinus headache, which refer to ENT clinic as it has a sinus headache. But usually sinus headache, it is not equally, it's about 5% of headache as usual we see. And we see a lot of cases of allergic rhinitis. We see there is a relationship between allergic rhinitis and migraine. And so we would like to diagnose that allergic rhinitis associated with migrainous effect in the treatment of allergic rhinitis on migrainous attack. Introduction. Ear, nose, and throat, ENT allergy immunology specialized frequency diagnose migrainous headache in their patient according to high prevalence of migraine and allergic rhinitis in population. Allergic rhinitis defined an inflammatory condition of the nasal mucosa, primarily mediated by an IgE-associated response. As we see that in our patients, such as pollen, dust mites, animal dandruff, which may cause allergic symptoms such as watery eye, runny nose, itchy throat, other causes in any allergic symptom. Migraine is a primary headache disorder characterized by recurrent headache that are moderate to severe. How to differentiate between headache and migraine? Headache usually often not localized, but migraine is usually localized at one side of the head. A headache usually doesn't affect the vision, but migraine usually affect the vision. Headache usually not light sensitivity, but migraine usually light sensitivity. Headache usually not affected by sense of smell, but migraine usually heightened by sense of smell. Headache usually relieved by painkiller, migraine not. Headache usually doesn't cause nausea and vomiting, but migraine usually cause nausea and vomiting. Headache usually doesn't last for 24 hours, but migraine affects the health and usually lasts for 24 hours. And the headache usually doesn't wake the patient from sleep, but migraine wakes the patient from sleep. Allergic rhinitis and migraine have many clinical similarities. It was seen that among patients with sinus headache referred to otolaryngology clinic, up to 75% may have history compatible with migraine. The reason for this correlation may be pathophysiology of this disorder. Pathophysiology, most disorders that have some trigger. Migraine and allergic rhinitis also have similar symptoms, such as smoke, odor, stress, travel, heat, change in weather, bright light, menstruation in female, lack of sleep, exercise, straining, any neck pain, any fatigue, noise, alcohol, food, sexual activity. The underlying mechanism for explaining the association between allergic rhinitis and migraine are complex and not well understood. Inflammation plays an important role in the complex pathogenesis of migraine as allergic rhinitis. Aim of a study to assess ability of allergic rhinitis treatment to decrease the attack of migraine associated with allergic rhinitis. Type of study. Prospective study to assess the effect of the treatment of allergic rhinitis on migrainous attack. The study placed on Otolaryngology Clinic in Suez Canal University Hospital and in Port Said General Hospital. This is Suez Canal University Hospital, and this is Port Said University Hospital. Inclusion criteria. Patient with allergic rhinitis and migraine, age between 18 and 48 years old, both sexes are included. Exclusion criteria, patient have nasal polyp and other any nasal abnormality and illness. Patient refused to participate in this study, pregnant woman. Sample size. The sample was systematic random sample of both male and female. Random sample, so we have about 85 sample, 85 patients. Methods. Patient diagnosed as allergic rhinitis associated with migraine. CPC with differential and IgE test done. Classified according to MATES, Migraine Disability Assessment Score. What is the MATES? We will discover it again. So observed taking treatment of allergic rhinitis, form of oral antihistaminic and local steroid for 3 months, and re-evaluated by MATES score to know the effect of the treatment of allergic rhinitis on attack of migraine. The MATES contains the following. That is missed in work, productivity in half to work, family or social activity, house to hold to half, household not done. Score, we put in maths score, 0 to 5, which have no pain, 6 to 10, mild, 11 to 12 to 20, moderate, positive 20, severe. Age distribution was between 18 to 48 years old. As we see from this as our result, we see this that the age is between from 18 to 20, with the mean age of about 40 years old. Sex distribution, which between about 21 male and 35 female, showing that they are more prevalent in female. Laboratory characteristic of the study patient. Hemoglobin was found between 10.80 to 20.4 milligram per deciliter, with mean of 11.37 milligram per deciliter. CBC was done to exclude anemia as a cause of migraine headache. IgE test was between 5 to 8 to 800 international unit per milliliter, with mean of 171.28 international unit per milliliter, done to sure diagnosis of allergic rhinitis and follow up after treatment. Medscore before treatment and after treatment. We notice that no patient in grade 1, no pain or disability, while majority included in grade 3. No patient in grade 1, as they have no pain, and the majority in grade 3, moderate pain or disability, that is before treatment. Media score after treatment among study patients. We noticed that the patient improved from allergic rhinitis and with the migrainous attack at the same time as the 43.1%, while patient improve with allergic rhinitis, but migrainous and the attack become less frequently, less severe in 15.52%. Patient improve with allergic rhinitis, but migrainous become less frequent and severe, 15.52, partially improve. Patient improve allergic rhinitis, but migrainous not improved, were 41. Patient not improved to allergic rhinitis treatment were excluded from the study, as we affect the treatment of allergic rhinitis on migrainous attack. We saw that the majority of the patient become in the grade 1, and there is mild in the grade 4. Partially improved in grade 2 and improved in the grade 1, and not improved in the grade 3. This is true that the patient improved from allergic rhinitis in grade 1 and partially improved in the grade 2 and not improved in the grade 3. Comparison of media score. Sorry. Comparison of media score before and after treatment of allergic rhinitis among the study patients. No pain, 0 before treatment, and 25 pain after treatment. And mild pain, 6 before treatment, and 9 after treatment. 44 patients moderate pain before treatment, and 19 after treatment, and severe pain 8 and 5 after treatment. We notice that statistically significant difference, that here we made comparison of media score before and after treatment among the studied of the patient, know the effect of the treatment of the allergic rhinitis of migrainous attacks. Notice that grade 1, no pain, showed statistically significant difference. Also, grade 3, moderate pain, show a statistically significant difference. IgE level among studies patient according to the patient improvement. We noticed here, IgE levels improve cases around 88.4 donate statistically significant difference within this group, not improved, where statistically significant difference, meaning high IgE level test is not improved cases. Grade ROC curve analysis of IgE tests. Receiver operating characteristic curve or ROC curve analysis is a plot of true positive rate against the false positive rate for the different possible cut point of the diagnostic test. Showed that area under the curve 79%, which mean accuracy of the test is fair, and the slope of the tangent line at a cut point give the likelihood ratio LR for the graph show ROC curve representing the good test. In our study, rhinoconjunctivitis quality of life questionnaire was done, and there was significant improvement for the patient regarding sleep problem, nasal symptom, particular problem, non-hay fever symptom, activities result also cope with the media score. Quality of life assessment by using ROC curve. Statistically significant difference that sleep not troubled, moderately هنا troubled, extremely troubled. Why هنا we saw that in our study rhinoconjunctivitis quality of life questionnaire was done. We saw that there is where significant improvement of patient regarding the sleep problem and nasal symptom, particularly problem, non-high fever symptom, activity result also cope with the media score result. Some other also the nasal symptom, the same that we see. Conclusion and summary. Allergic rhinitis and migraine are very common disease and both carry a huge socioeconomic burden worldwide. The relation attract our interest to study the effect of treatment of allergic rhinitis and migraine. In our study, we used intranasal corticosteroid spray and oral antihistaminic for 3 months. Decrease in the prevalence, frequency, and disability of migraine headache found partially improved patient found in our study and not improved referred to neurologists. This was proven by the effect of the treatment of allergic rhinitis in improving the media score used to assess the migraine and the overall quality of life. Quality of life assessment clarifies the role of the treatment and its real benefit, which here is showing significant improvement. Recommendation: follow up for longer period, wide range of each group, children, geriatric. Further study to assess the role of nasal corticosteroid only in the treatment of migraine. IgE test recommended in follow-up. Studied to assess the antihistaminic level in patient having both allergic rhinitis and migraine. Thank you. Any question?
Thank you, Doctor, for your presentation. If any of the participants have any questions, they can go on and ask. Okay, with this, I would like to end today's session. As there are no questions to ask, if anyone has to discuss anything, any live discussions, if there, you can go on. Okay, with that, I would like to thank you all for your precious time and for this virtual session, having me as a moderator for this great session. We expect that all of you got a good experience from our session. Also, we have successfully completed our on 2 days conference, and all of your participants' certificate will be sent by the end of the day via email. Thank you, and I wish you a great day ahead. Thank you so much.